And ask our secretary to call the roll.
Sure. I will start with you, Commissioner Chow,
Yes, present.
Commissioner Green,
Present.
and Commissioner Christian.
Present.
Thank you. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homelands. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the agenda are the minutes of February 27, 2024.
Thank you. So commissioners, the minutes are before you and a motion is in order.
So moved. Move to approve.
And is there any public testimony?
No, I'll make the blanket statement that no requests for remote public comment were made, and all we have are staff in the room. So I'll let you know if there is public comment, but I think we can move forward without.
Okay,
any.
good. So we'll proceed with the vote. All those in favor, please say aye.
Aye.
Aye. All those opposed, and therefore it is unanimously accepted.
Wonderful. Let's move on to item 3, supporting safe and joyful Black birth through respectful care. I will pull up the presentation. Okay, our presenters are doing so remotely, and y'all could begin whenever.
Great, thank you so much. Can everyone hear me?
Yes, you're coming in loud and clear.
Great, perfect, thank you. Buenas tardes. It is my pleasure to be speaking before the Health Commission today on a topic that is so critically important and personally relevant to many of our staff, patients, and community. My name is Ana Delgado. I'm a midwife and a member of the UCSF Department of OB-GYN at ZSFG, where I am the co-director for anti-racism, equity, inclusion, and structural change. I'm joined today by Sinead Williams and Mia Short, who will introduce themselves prior to their remarks. And we will be talking to you about how we're supporting safe and joyful Black birth through respectful care. We're going to take you on a journey today to explore the multifaceted care model we have been building to support Black birthing families to have safe and joyful outcomes. Next slide.
Sorry, give me 1 second. I got off path here.
Sure.
There we go.
Okay. And first of all, I need to give credit for these slides to my colleague Asmar Gebre, who is much better at making slides than I am. You will tell the difference between my slides and her slides. So I'd like to start with first highlighting 2 programs that Asmara, also a midwife here at ZSFG, has founded. First, the slide is about our comprehensive Black centering program. So Black centering is a care model that brings Black pregnant folks together who are due around a similar time to receive both midwifery care education and social support. Centering pregnancy, some of you may be familiar with this model, but just in case, is a nationally recognized evidence-based model that is now seen as the preferred way to deliver prenatal care. Our all-Black team consists of midwives, student midwives, medical assistants, and nurses, and the groups meet on a regular schedule. And through this connection, also gain access to other services, such as cooking classes held in a local Black-owned and operated restaurant in the Bayview, CPR classes led by local Black Nursing Authority members, healthy postpartum meals through a collaboration with Postpartum Justice, a community-based organization, books from the Children's Book Project, home delivery of baby goods and other essential items through One Love Black Community, another community-based organization, and the opportunity to build community and gather together at places like the Museum of the African Diaspora and the SF Botanical Gardens. Centering pregnancy is the only prenatal care intervention known to reduce the rates of low birth weight and preterm birth in Black women, and we're proud to offer this model to our patients. Next slide. One of the hallmarks of our Black centering model is the leadership of Black midwives. And unfortunately, Black midwives only make up around 6% of the national midwifery workforce. To that end, Asmara has also founded a Black Midwifery Fellowship here at ZSFG, and we just graduated our first fellow, Alexandra Mitchell, in January of this year. This fellowship is one of only 2 fellowships of this kind in the entire country. And it's a focus on sharpening traditional midwifery skills, but also providing access to much needed abortion training through the California Reproductive Health Services Corps. And we also connect our fellows to other Black healthcare providers, both locally and nationally. And we have a new class of fellows that will be starting in fall of 2024. Next slide. One of the other hats that I wear as is Director of OB Quality Improvement. And I'm keenly aware that care needs to be at minimum safe in order to qualify as respectful. I would like to briefly share some of the work that we have done in the area of patient safety. We have consistently been early adopters and in some cases co-developers of nationally recognized toolkits and care pathways for the prevention of key conditions such as postpartum hemorrhage, hypertensive crisis, and unnecessary cesarean section. We do this through a combination of standardized checklists, emergency simulations, judicious use of interventions, and team communication standards. We know that our Black patients have higher rates of adverse events, and this is not obviously limited to our hospital. And we're working diligently to better understand for our patients what are the drivers behind these trends to target improvement. For example, in a recent review and deep dive into our cesarean section data, we determined that the cesarean section rate for Black patients was being primarily driven by the higher than average induction of labor rate in that population. So we have modified our induction of labor protocols to try to reduce the number of unneeded inductions overall, but particularly with an eye towards improving care for Black patients. We have also instituted numerous tools to make sure there is a shared mental model of what the optimal care plan is for each patient so that the whole care team is on the same page. And here I've just put a snippet of our post-birth debrief where we recap the birth, including a labor course and the delivery with the patient and their family and the bedside nurse to make sure that everyone is on the same page about any outstanding medical concerns and necessary treatments, including the patient and her family. Next slide. Finally, I'd like to situate this work within the overall strategy in the maternal child health service line on the inpatient side in particular, where we commit to respectful care through training, direct community involvement. We have a community accountability board that reviews our policies and protocols. We also work very closely with patient navigators, public health nurses, and doulas. And we intentionally solicit patient feedback by providing them a variety of ways to reach us and to provide us their opinion. We also have a comprehensive toolkit that supports us to give each other feedback, interrupt racism and bias, and de-escalate situations, and most importantly, help families stay together and avoid any involvement in the child welfare system. Because of this work, we are recognized by Birthing Cultural Rigor, a nationally recognized and Black-led OBQI organization, as the San Francisco hospital with the lowest scores for obstetric racism across 3 independent and validated domains of patient-reported outcomes. We also outperformed the mean on the same scale administered to over 800 Black birthing people in over 340 hospitals across the United States, including 34 states. So we're very proud of the work we've done, and we know we have much more to do. And with that, I'll turn it over to Shanita Williams to share some more.
Hi, hopefully you all can hear me. Thumbs up.
Yes, loud and clear.
Oh, great. My name is Shanita Williams. I'm a community engagement coordinator across 3 different initiatives. One is our Solid Start initiative at San Francisco General, and the other is the San Francisco Respect initiative, and also the Black Women's Health and Livelihood initiatives. And I'll introduce a couple of our collaboration programs on the next slide. And so with the San Francisco Respect Initiative, along with the synergy and alignment with the mission of the Solid Start Initiative, we have did a design sprint and listening to community for the past 5 to 7 years, and we're now in our 3rd year of showing up in community, the Bayview community specifically, where we have our pregnancy pop-up village. And so the pregnancy pop-up village is looked at as a one-stop shop based off of what community says that they need and desire to show up and do services in a different way. So not only is it stepping out of the institutional space, it's also allowing the providers that are stepping into the space to show up and provide services differently outside the box of their organization restraints. And so we chose Bayview, and we pop up every second Saturday because of the largest health disparities, and we're prioritizing our publicly insured, Black identified pregnant people and their families who are getting care across San Francisco. What's unique about the village is that we take all of our direction from community. We also have an advisory group where we hear community's experiences, feedback after each experience at the pop-up village through one-on-one interviews. And that is how we continue to drive our change and how we continue to show up. We also pride ourselves on not showing up as being a health fair. Each organization that is either a government organization or a community-based organization is there to show up and provide a service. And so, for example, community members are able to show up and sign up for their Medi-Cal, for their WIC, food stamps on the spot. We have a mobile unit, which you can see here in the picture. Our community are able to talk about their pregnancy options, get pregnancy tests, even get an ultrasound. We have a team of providers who include midwives, OBGYN staff who also show up at the mobile unit. And we also are broken up into different sections. And like I said, one-stop shop for the community. So we know that it takes a village for the community as a whole. So we are the health and wellness anchors of the village, but there's also a youth zone. There's food and agriculture, showing up with organic produce and food. We do community lunch during the pop-up village. We have a fatherhood lounge. Everything that you could think of that embodies the experience of the family as a whole. We recently moved to a bigger location because we happily outgrew our last location, where we first started out with only 6 different partners, and now we are up to, wow, we're up to over 100 different partners showing up in different ways. And so we are now at the Southeast Community Center, which is a brand new partnership, and continuing to show up with the experience and showing respectful care for the whole family in that way. Next slide. Okay, and so like I said, the missions always align with different initiatives. And the other thing that we think of respectful care is strength with community collaboration. And so one thing that I've heard from our advisory groups and accountability boards all the time is that some of the services I heard about too late. I wasn't a part of a community-based organization, but how come I didn't get to know those services just at my regular hospital visits? And how come that there's no one that resembles me or looks like me or can advocate for me when I'm at, my hospital visits on site or getting my prenatal care? And I think a perfect example of this integration is the Solid Start and ZSFG coming together and collaborate with community-based organization. And here's an example of collaborating with the Homeless Prenatal Program. And so over the years, this has become more robust as we learn more from what the patients need. And so you have community health workers that are in an apprenticeship program at Homeless Prenatal being integrated into the institution, where they're on site, able to work side by side with different providers, and also with our Solid Start care navigation team, which includes a lead navigator. We have a community health worker manager. We also have a mental health clinician, Mia, who introduced herself as well, who come together, work together, provide assessments, are able to advocate on the patient's behalf in real time. Patients have access to also get connected to the Homeless Prenatal Program while they're on site having their visit at the hospital. And we're also able to connect them to the essentials that a lot of our pregnant patients always name as a stress is how do I get all the things I need for my baby? So helping them navigate through different systems, helping them get to their different clinical visits, and also not just in the perinatal space, but over transitions of care and what it looks like for continuity of care to have someone with you along getting prenatal care, moving on to pediatrics, and then having your own care as an individual with your primary care. And so that is some of the example about collaborating with community organizations and how this is a model of integrating their staff and providers into the institution. Thank you. I'll hand it over to Mia, who can introduce herself.
All right. Hi, everybody. Are you able to hear me?
Yes.
Okay, great. Hi, everyone. My name is Mia, and I am the perinatal mental health clinician with Solid Start. And I began seeing patients in January of 2023. And since then, there have been 52 Black identifying patients that have been connected to race concordant mental health services. So I'm able to meet with families or patients beginning in pregnancy and then following them into the postpartum period. So it's been really great to be able to build relationships with people during pregnancy. And then being able to provide a space with them to share their birth experience after they give birth in the hospital, and then be able to provide support in the postpartum period when there can be different type of mental health symptoms that arise, as well as being able to connect patients to other services and things they might need. So one of the things has also been trying to get patients connected to primary care after they deliver their babies. So care for themselves, care for their babies, as well as other kind of community-based organizations and things that they need in addition to mental health services and the things that we offer in FIDEM. And then, so what is next? We will continue to do this work with Solid Start as well as the other clinical leaders at the General. And then with Medi-Cal's new CalAIM initiative with the Birth Equity Population of Focus, Solid Start is one of the Anthem and San Francisco Health Network approved providers for enhanced case management services for pregnant and postpartum people. So this is another service that we're able to offer our patients. And all Black identifying pregnant and postpartum people will be ECM eligible through the Birth Equity Population of Focus starting in January of 2024.
That concludes our presentation of our innovative care model and programming. And don't know if anyone has any questions or if any of my co-panelists have any other comments they'd like to add at this point.
Thank you very much. I'm sure we have certainly appreciated the presentation. I will now ask my fellow commissioners any questions since you're saying we have no public comment.
Yes, sir. No public comment.
Okay, so Commissioner Christian?
Sure, I'll start it off. Thank you. Thank you all. Thank all three of you for the presentation, all four of you for the presentation. And this is, such important and amazing work, and groundbreaking, clearly. And I think it is interesting that we're receiving this presentation today, given the Supreme Court arguments on the availability of mifepristone for women and the effort to take it away. And I am not a physician, and so I, don't know a lot about the OBGYN space other than being a client. But on the first slide, you talk about, or a second slide, you note that there's a focus on abortion training in the midwifery fellowship. And I recently heard a radio piece about the importance of hands-on training for abortion services and what it means to have them taken away, that kind of training and access taken away in throughout the country, and what it means to students who are learning, medical students who are learning, they don't have the opportunity to really learn how to provide this medical care to women. And it's something that really requires hands-on training. And so what we're facing across the country is the loss of generational knowledge and skill and ability to perform these services for women, which is really, a follow-on effect that I think people outside of the medical profession don't really think about, and how frightening that is for women's health. And so that also, listening to that program, took me back to one of my very first commission meetings when abortion was still safe and legal in the country, mostly throughout, and hearing our medical staff talk about preparing for a time when that might not be the case. And it was really striking to think about and feel that the possibility and the likelihood of that reality. And once again, the foresight and the planning and the dedication of the San Francisco hospital people preparing for this time. I just have to praise and thank you all again for that. And so one of the questions that I have, you've touched on it, but I just want to be clear about who is eligible to access these services, these resources. How much of it depends on a person's ability to, whether they have private, if a person that has some private insurance, can they access these services, or is there a way to get them to these kind of incredibly uniquely supportive services for Black people who are pregnant and birthing?
First of all, I'd just like to make a brief comment about your initial statement, and thank you for recognizing the importance of abortion care. I will say, as a midwife, we were the original abortion providers back in since biblical times and moving forward, and I will guarantee you that knowledge will never ever go away. So we will do that. We will do that for our people as long as it is necessary. And with respect to your question, I think this is one of those things where in some respects, it might be a slight advantage to be publicly insured. There is a very, very beautiful sister program of ours at UCSF, which Sinead can speak more to, that does attend to Black birthing folks who are privately insured. But at San Francisco General, as you may or may not know, we're not contracted really to provide services to those with private insurance. So we only, with a couple of exceptions, which aren't worth going into here, but we really do focus on the publicly insured, and that has to do with the mission, really, of our safety net hospital. Yeah.
Absolutely, and I definitely support that. I was just wondering about the people who need this and who have private insurance, which these days is not as extensive as it needs to be, and the knowledge that I do have about these outcomes, these negative outcomes affecting Black pregnant people, Black birthing people across the spectrum of education, income, and so much of it being somewhat outside of the narrow focus, the care that's being provided. And so the fact that you have these programs and these amazingly skilled people providing supportive services that does increase the health of the Black family and the people who are giving birth is obviously so incredibly important. And I just want to thank you and for your the incredibly intelligent way and deeply intelligent ways that you are providing these services and creating the structure for the community. I think I'll stop there and let somebody else ask some questions.
If I could add to that, I do want to say that a lot of the services that we connect people to, especially at the Pop-Up Village, are services that are most utilized by our publicly insured population, but are offered to people with all type of insurance, even no insurance. So for example, surrounding the family with a village can look like hooking them up with Black Infant Health, program, still being able to align them with a doula that is not focused on insurance. There's Rafiki Coalition, who does some mental health services regardless of your insurance. And then the other part that we're learning is the education of our community, who sometimes assume that if you are publicly insured, that you don't have a lot of options. And so a lot of our publicly insured population gets services at ZSFG and don't know that you can have Medi-Cal and go to UCSF. They don't know that you can have Medi-Cal and get, if you prefer to go to Kaiser. And so we have the government agencies showing up who are signing them up on site to give them their options. Because like Anna mentioned, here on the UCSF side, where I'm sitting at right now, in our lovely Black Wellness Center, I'll say, there's a program called Embrace that does centering pregnancy similar to ZSFG, and most of their participants are privately insured, and they might not know that they still qualify and can take part in the other community-based organization services and may just assume. So it's about, a lot of just educating the community on both sides and surrounding them with wraparound services and a village, that I like to say.
Thank you so much. It's incredible work. Thank you.
Thank you. Commissioner Green?
Yes, well, thank you so much for your work in the presentation. This is not only groundbreaking work, as Commissioner Christian said, but I think it's foundational. So I have a few questions in that regard. One is, I was thinking as you were presenting about back in the 80s when HIV, the approach to HIV was really developed here in San Francisco, and then ultimately was used as an example of care throughout the country. And I see this in the same way. So what I'm wondering is have you thought about how you are going to spread your structure around the country, knowing that there are so many more barriers in other areas of this country besides San Francisco? Can you take what you've done and make like a package? For example, I know there are centers, for example, that have excellence in spine surgery, and the people from wherever that is come to other universities and will, show them how they've structured it and kind of go through, so other organizations that may not either be as well funded or as motivated cannot hit potholes that then naysayers use as an excuse not to move forward. Because I think it's so important almost for you to think about how you can franchise this, basic, next level. And I'm sure that is very complicated because it involves in public funding that other jurisdictions may not be interested in, but it's so important that you spread this across the country. So I'm wondering, how you've thought about that. And then, kind of as a correlate to that, the other organization that I think is looked at across the country as setting standards is the California Maternal Quality Care Collaborative. And I'm not sure the extent to which you've interacted with that organization. They've done, I'm an OBGYN, by the way, I actually trained at the county, and I hate to say it, but the late 70s, early 80s. So I delivered a baby this morning. So I do OB at CPMC, and I've been very concerned about what's going on. And in fact, another correlate to this is how do we find women, where is the portal of entry? We see some women that come in who haven't had prenatal care, and we would like to put them into programs or inform them, but I don't think we know. And I'm sure Kaiser is another system that could utilize the services that the patients could. So, but back to this whole issue of how you can make what you're doing more nationally available and as a guidance for other organizations. What's your thinking on that? And especially, I think the CMQCC, which has a lot of national impact.
Yeah, I know that my colleagues here have also been very well sought after presenters at national conferences multiple times. I've seen their work disseminated in that venue. And we also disseminate our work really to anyone who asks. We're about, because the community has basically helped us design this work, we do not consider ourselves owners of it. It is very much owned by the community, and we want to make sure that the benefits accrue to that community, whether that be here in San Francisco or elsewhere. But I will say that, you know, we are focused on service delivery as our primary goal. And that aligns, of course, with our mission, as I said, as a safety net hospital. But, you know, any funding that one could receive to help with dissemination, we would not turn that down. And also, I'll say that we have been working with CMQCC since basically CMQCC started. We were one of the first hospitals to partner and become part of the maternal data center. And I'm actually presenting at ACOG this May here in San Francisco on severe maternal morbidity alongside Elliot Main and Elizabeth Howell and other leaders in the field to really think about using an equity lens to think about severe maternal morbidity and how to prevent additional harm accruing to Black birthing folks. So we definitely have an eye towards that. It is not, I would say, our first order of business, because we do really care deeply for the pregnant people of the good pregnant people of San Francisco, as I like to call them, and really serving them and making their lives joyful and having the families thrive is our #1 priority. I don't know, Shanita and Mia, if you wanted to add anything else to that.
No, same as you said, you know, so far I've been to present at many different states on the work that we are doing. And definitely, I think the main thing is sustaining and starting at home, and knowing that we're on a journey to like really rebuild trust with our Black community, with our Black identified patients, and that the #1 thing that usually falls short and keep the cycle going is that things start up and then things get taken away. Things start up and then you can tell that they're making some type of change, and then due to funding or grants or philanthropy, it's taken away, and it continues the cycle of our patients and the people that we're on the ground with to just trusting us. And if we continue to have to keep begging, building trust, is, you know, hard to focus on other situations. But I do think that opportunities to present, I think I'm going to try to go to APHA again. I've been a few times this year, present this work, engaging communities around prioritizing research opportunities as another presentation. But definitely on the groundwork with the patients, but learning also from other people doing it different ways and offering ourselves as a model for other people doing things different ways. And we always meet people all over the country that are doing things and hear what we're doing and want to learn more. So I really love the idea about how to package this and frame this and present it in that way.
Thank you so much. And how are you integrating with other organizations in the city? For example, Expecting Justice. I know they've done a terrific program of giving resources to women who are pregnant, and also the various postpartum that RAMS, I believe, we just approved a contract with RAMS that is going to give postpartum through I think through year 2 of life or something. How are you kind of putting all that together as a package so that, you know, birthing people throughout the city can know what's available? I think that was asked by Commissioner Christian, but I'm wondering, are there other organizations? I was looking to see if the RAMS Expecting Justice were on the PowerPoint, and I didn't see them.
You want to go, Anna? I mean, I think in my community engagement.
Yeah, I'll let you take that first crack at that, but I can fill in some stuff as well.
Yes, please fill in. I think for myself in community engagement, I'm not just a one-woman show. I do have a team, but I do pride myself as staying on top of the different resources, maintaining and building new partnerships across the different organizations, and being in spaces and places to share the work that we're doing, and also opportunities to collaborate. And I did mention some of the government agencies showing up to the pop-up village, but each organization that is committed and shows up every month to provide service includes people from Expecting Justice, Abundant Birth, from our doula program, Sister Web, like I said, Black Infant Health, Homeless Prenatal Program. We have monthly convenings with a lot of the different health and wellness partners to talk about the way that we show up and the way that we do work together. And so a big part of what I'm doing, especially being a part of 3 different initiatives, is always looking for alignment and synergy and sharing it back to the leaders of the different initiatives about ways that we can collaborate and work together and not duplicate the wheel and to not be in silos.
Well, thank you again.
Yeah, and
for
I
this.
mean, specifically
sorry.
to RAMS, we're working with specifically Dr. Jay Watkins, who's at RAMS and also works both in the Embrace program and also participates very, I think on a monthly basis at our perinatal linkage meeting, which is an important meeting that takes place and is led by our colleagues down at the department, at headquarters, as we call it, downtown. Liliana Osegueda and Angie Miller lead this meeting where they bring together all of the different stakeholders that are taking care of prenatal people. And so Expecting Justice, the Embrace program, Pop-Up Village, the doulas, all of the clinical areas, we're all represented there, including WIC, public health nursing. And we really try to talk to each other so that the patients don't have to do the work that we should be doing to coordinate these care pathways so that they can get what they need and get it easily.
Well, thank you so much for answering these questions and for this really exceptional work you're doing. I think we'll look forward to hearing more. And again, I would encourage you to toot your horn in as many presentations as you can, because this is desperately needed throughout this country and there are a lot of barriers. So thank you so much.
Thank you.
So thank you, Commissioner Green. And following up then, I'd be interested in this last slide of yours, what's next? And being that, you have been in this program for about a year, bringing together all of the different resources in order to assist the Black birthing situation. And I'm wondering what you're intending to use as sort of the guideline for success. And are you looking back on, well, for example, you have 137 Black pregnant women. Does that compose the entire number of deliveries on the part of the Black population here at General? And if not, are you intending to be inclusive of all of them? And then what are the outcomes that you're looking for that will then indicate that this type of program really has a successful outcome versus not having the program?
Yeah, so first of all, each of these programs does have an evaluation component that we didn't actually highlight super clearly, but there are evaluations kind of happening on an ongoing basis. For example, at the Pop-Up Village, there's an entire evaluations team that is working on making sure that we're meeting the goals that the patient set out for us in the first place, which was, navigating to important services, making sure that patients are having a good experience. And so each program, depending on the goals of the program, does have an evaluation component. I do think that it's important to look at our own data for sure. However, because of the lower numbers and the great thing about birthing and obstetric care in general is that adverse events are actually quite rare, even in high-risk populations. It can sometimes be difficult to show that you're moving the needle when you're looking at such a small number of people. And so we will be looking at our data, but we also don't want to, rest on our laurels, so to speak, and say, oh, our data is looking stable or better, or like overly rely on that, because it's just going to take so many. We need a much larger N to really show movement in such a short period of time. So we're looking a lot at state and national data as well. and also historical data. So data we have in our databases from even before CMQCC was around. So we are going to be looking at that data. But I think most importantly, I honestly feel like the patient reported experience metrics are the things that we really need to be focusing on, because we have for far too long focused in OB care on the things that we care about. And honestly, the patients are not always caring about the same things we care about. And we need to be focusing on what they care about. And this issue of respectful care is really top on their list. And so when you look at surveys like the Listening to Mothers survey, for example, birthing people will report that what mattered most to them is how they felt while they were being cared for, not the outcome per se. So whether they had a C-section or not, or whether they had to have their labor induced or not, or whether they, had a postpartum hemorrhage or not, does not actually matter the most to them. What matters most to them is, were they treated with dignity? Was their family respected? Were their decisions respected? Did they have bodily autonomy? Were their culture and their values incorporated into their care plan? Those are the things that matter to them. And there are national tools that measure this. And that was the one I mentioned during my presentation. And we are currently still working with Birthing Cultural Rigor. We attended the conference that they hosted last fall, and we'll be attending again this year to really keep working at that and looking at that issue and making sure that we are moving the needle.
Well, thank you. Clearly, as you working with your community partners, and sounds like you should probably have your pop-up mobile more than just once a month from the success that it sounds like. And those are all measures of success in seeing that, even post-birth, you've got a network going. And I think you've already shown one success, showing that you were able to actually place 52 people into the needs for their mental health. I think those are the kind of outcomes of the type of program you have. Clearly, of course, the usual, outcomes in regards to any birth is sort of important. But I think you really hit on the fact that for this to be successful, it isn't just seeing what type of complications or non-complications, or whether you get 9 months of treatment or not, but what is the outcome for the entire family. And I'm really pleased that that's what you're looking at. And in any future presentation, it'd be really interesting to see that this type of model program working on behalf of actually the social determinants of care have really made a difference in the lives of people, not just merely the one point of delivery. So thank you very much for the work that you're all doing, and we wish you well.
Thank you.
Thank you. Appreciate it.
Thank you.
Thank you.
Appreciate you.
Thank you, everybody. And we'll move on to our next item, please.
Sure. Thanks again, presenters, for your great work.
Thank you.
Item 4 is the
Thank you.
Regulatory Affairs Report.
Good afternoon. Hopefully you can hear me successfully.
Yes.
I see
you.
a head nodding. Excellent. And I just want to apologize for not being there in person, but we are hosting some visitors, some surveyors from the CDPH. So we are trying to juggle as best we are able. So hopefully also my screen is now being shared. If that's not the case, please let me know. So in terms of our pending surveys, you can see there the top line is the Joint Commission Medicare Deficiency Survey. So that is the revisit that is stemming from our triennial survey that we had February 13th through the 16th. We are anticipating that that will happen by Monday. So their officially stated return is within 45 days of that survey, which would be Monday. But as every day inches closer, I get a little more suspicious that maybe that won't happen. Also of note, at the bottom there is the Commission on Cancer survey that is scheduled for this Thursday. It is in person. And also our Joint Commission laboratory survey opened on Monday. Is everything okay? So with that, it is entirely possible that by the end of this week, we will be having 3 concurrent surveys. But we are giving ourselves the best shot from there. All right, in terms of survey activity, so again, February 13th through the 16th, we had our Joint Commission Hospital Accreditation and Nursing Care Center survey. So in total, there were 51 elements of performance for the hospital and 4 elements of performance for the nursing care center that were cited. And you can see there, the first section has listed the findings for which they intend to return. So those included an environment of care, so dust in some clean patient rooms, competency assessments of performing high-level disinfection of TEE probes. There were a number of findings that you see down there under infection control related to TEE probe cleaning. Additionally, because of that, there were some other kind of surrounding findings related to infection control, which included some expired hand sanitizer, bleach wipes, and procedural gloves, general cleanliness of ultrasound probes, reuse of extension tubing, hand drying method when scrubbing in to procedural areas, storing of sterile procedure kits, and then use of enzymatic spray on soiled instruments. And let's see if we can get to the next page here. Additionally, there are a number of other findings that are not officially a focus of the revisit, though certainly if they see something of concern, they will be citing it again. But they are things that we have to respond to the evidence of standards compliance within 60 days. So that's we're looking at a target date of the end of April to have the responses complete. And those findings ranged from environment of care, human resources, leadership, life safety, medication management, med staff, provision of care, and rights and responsibilities of the individual. And at this point, I would like to go ahead and pivot from this presentation to the questions that were submitted by the commissioners to specifically address those findings, and then I'm also happy to speak about any others to the best of my ability. So the first question had been about what findings were related to OPPE, also known as ongoing professional practice evaluation. I always have to remind myself of that one. And so I've put them up here on the screen, but you can see that the first finding had to do with the lack of defined frequency at which the data was being used for OPPE and how often it was being obtained. And the second finding had to do that in 2 of 6 credential files reviewed, there was no evidence that OPPE had been completed, and those were specific to a nurse practitioner and a certified nurse midwife. So in both cases, that leadership team is working on addressing those issues. The next one is asking what the findings were regarding preferred language and documentation of advanced directive under rights and responsibilities of the individual. Excuse me. So the first one had to do on a consent form and the wound care clinic, that the consent was done in English, while the preferred language for written communication was Spanish. Upon further investigation, it was determined that the patient in question had recently turned 18, and his preferred language was in fact English, but his mother's language was Spanish. So when he turned 18, we had not made that adjustment in the chart. So in the spirit of what was for the patient, it was just that the documentation didn't align with that, but they are working to address that. And the second finding in this section had to do that there was not documentation. So if it's not documented, it wasn't done. That patient was asked if they had an advanced directive or wanted additional information when they did the nursing standard of care admission. So again, work is being done to address that issue. The third question that we had was, how do the 2 results of these 2 surveys compared to previous findings from Commissioner Green? So I've put on the left-hand side of the screen here, you can see our 2021, so 3 years ago, our SAFER matrix. So again, Joint Commission provides us kind of a novel mechanism for viewing this, and it is color-coded and graded. So the left-hand side represents our 2021 findings, and the right-hand side represents our 2024 findings. And there are more findings this time. So there were a total of 42, if you include both what is posted on the screen plus Nursing Care Center, which is the 4A skilled nursing. It gets its own survey, versus there were 55. for this year. But the two things that you want to highlight as an explanation for that is, first, you will notice that we actually only had one item this time that was in the high widespread column and nothing in the high pattern. Whereas last time there were several of those. So overall, we do have more findings, but there were less that were of the same scope and severity. The other thing is, it is my current understanding from colleagues around the country that Joint Commission is currently getting a great deal of pressure from CMS about seeing right at cited. So essentially, if anything is seen, it is being cited. The other piece is that coming out of COVID, collectively, hospitals are having a significantly greater number of findings. It was described to me by someone who is well versed in this that we quote unquote worked special, meaning that I think every hospital is having similar issues kind of coming out of COVID and kind of managing what does the hospital landscape look like, especially given the focus of the foci on high-level disinfection and kind of general infection control practices. And then in terms of, there was also a question about if there were any recurrent findings from survey from Commissioner Green. So I took a look at the 2021 findings, again, that you can see on there, and there were a handful of similar findings. Again, some common ones that we would have anticipated. Power strips is a frequent issue. They are everywhere. They grow legs and walk around at night, I swear. A couple of open junction boxes. So again, just a single electrical box was open and we got cited for that. Some outdoor storage of medical gas containers and sort of the covering and safety of those. High-level disinfection was a focus 3 years ago and was still a focus today. Again, that is something where they look at it with increased scrutiny, and every time they come in, they're like, okay, that part you fixed, but now let's deep dive into this. So that absolutely is a common one. And then the other two, one would be penetrations and smoke barriers. So as you know, there's a great deal of construction going on, just again with the seismic retrofits and everything. And every time an additional set of cords is pushed through a ceiling, there needs to be that barrier put up. And so that's an ongoing challenge. And lastly, assessment and reassessment of pain. So again, something that we continue to work on, but it is an ongoing challenge of making sure that we are fully taking care of the patient's pain to the best of abilities, and then also fully documenting it. So those would be some things that were identified as similarities. But overall, again, I would say it was roughly as anticipated. And the last two questions, so there was a question from Commissioner Green about what were the examples of medication titration. So I've put here the observation. It specifically had to do in the ICU about a Levophed drip. And the order was to titrate 2 micrograms per minute, but the drip was sometimes being titrated upwards of, it looked like 6 micrograms per minute, which was permissible. It looked like the further they dug into this chart, what the surveyor was really looking for called block charting, which, as not having a background as an ICU nurse, was alerting for me. But essentially, this patient was very unstable, and they were taking excellent care of the patient. But in terms of the documentation, it didn't have the summaries to demonstrate kind of all of the things that had happened during the course of them having to rapidly titrate up and down. So again, that team is working to actively address that. But it wasn't about a care issue; it was a documentation issue, which again I would describe as a theme for what our findings were. It really wasn't about the care, it was about the documentation. And the last question that we had formally was, why did they focus education on hypertension / preeclampsia? And the reason is that there is a provision of care standard 060301 EP3 that is specifically about reducing the likelihood of harm related to maternal severe hypertension and preeclampsia. And this is a relatively new standard, but they actually go into detail that at a minimum, we need to be providing this education whenever procedure changes or every 2 years. And so the findings with that is that they were able to see some evidence that nurses and the residents had received this training. But in terms of the attending physicians, as well as the nurse practitioners, it was more up to their independent professional practice. We didn't have like one class we put every provider through. So again, there's some ongoing conversations about how to best address that. And then for a single staff member, when they did a chart review, there was they didn't have evidence of that. So they're also working to address that. So those were the 6 specific questions. I will pivot back to the rest of the report, which should be relatively brief, and then I'm happy to take additional questions. So there were not any plans of correction submitted during the month of February that we have to report. In terms of CDPH reported events, there were 4 reported in the month of February, which brings our yearly total up to 8 so far. So of those, there was 1 delay in care, 1 facility issue, 1 COVID outbreak, and 1 sexual assault that were reported in February. And you can see there the totals, which we have 2023 as a comparison, and what has happened thus far in 2024. And lastly, we do not have any monitoring data to report this month because due to the HICS activation that was that facilities issue, we had to cancel the accreditation committee, so nobody was able to report their monitoring. So we will have more on that next month. So with that, I will stop presenting and ask what questions.
Well, thank you. Commissioners, and thank you for answering the questions which we had forwarded. It helped a great deal. Commissioners, questions?
No
Commissioner
question.
Christian?
Thank you very much. Thank you for the presentation. So just, from a layperson's perspective, can you explain a little more about, so there are these discrete findings and of things that they found to be some way deficient, and you say something like it's an ongoing effort to address it. Can you explain what that means, kind of in practice when the rubber hits the road? You get these findings and you go back to the teams and say, okay, so what do you say?
Great question. And yes, absolutely. I think the biggest piece to kind of understand the difference between Joint Commission and CDPH or CMS is that when we get the plan of correction for the state or CMS, we get 10 calendar days to respond. And so it's this scramble of like, we've got it, we got to get it done and go. Whereas with Joint Commission, the things are falling into 2 buckets. So for the things that they are revisiting, we need to have them fixed when they come back to see them in person. It's you could say trust but verify, which really isn't trusting. They are going to come back and verify. And for the rest of the things, for everything, we're providing a written response, but we have 60 days to do it. And so again, that is still not long enough to make capital improvements. If we need to get a permit or something to do physical work, that's not enough time, but it is plenty of time to kind of think through these things and have discussions. And so what I will say, I think to most specifically answer to these items here on the screen that they're coming back to revisit is, we got these findings upon exit. So back officially on 2/16, we had to wait about 2 weeks to get the finalized written report from them, but we started working on them immediately. So the week after the survey, we had meetings. The quality and regulatory teams had meetings with every one of these citations that they were coming back to visit and talked through what are we going to do about this. And for some of them, it's as simple as there was an expired hand sanitizer. We're going to throw the hand sanitizer away, right? Like that's the base action. And then we kind of want to expand it out from there. So it's, well, if this one's expired, is that the canary in the coal mine? We need to start looking, how far out do we need to expand our search? And then how are we going to fix the system to prevent that from happening? So it's really kind of trying to go through systematically. I've been describing it as concentric circles, that we want to fix the immediate problem that they have identified, and then we want to work our way out to the best of our abilities to address the problem elsewhere. Typically, for most of these things, education is going to be, it's a low level action, but it is an action of letting staff know what the findings are and then kind of helping with their awareness. And then for almost all of these findings, we are required to provide, the Joint Commission likes to have their own terms for everything. So sustained compliance is their phrase, but monitoring is kind of our local colloquialism. And so for almost every one of these, there will be some form of monitoring data where for the next 3+ months, we are actively kind of surveilling, have the actions that we've taken actually made a difference?
Thank you.
Hopefully that answers your question.
That's helpful. Thank you.
Commissioner Green?
Yes, well, thank you for the presentation. And, you know, you always think for an institution with patients of this acuity that is this complex, that it seems to me that 85 discrete findings is probably pretty darn good. I wondered if you know, I have asked before, I think, in, you know, any context in terms of other, you know, similar institutions. And when they leave, they have to obviously list these things. But did you get any feedback how, you know, you might benchmark to similar institutions?
Sure. So officially, they don't give us it's state secrets, if you will, from other hospitals. I think there actually are some whisperings coming down that CMS may be forcing them to be more open about it, which I think to many hospitals might be very concerning. Again, we have a very transparent record, so I feel relatively. I'll be interested to read what other people's issues are, certainly. So officially, we don't have a number. What I will say is that we do have a volunteer on the regulatory team that has extensive regulatory experience working in a similar setting and also acting as a surveyor for Joint Commission. And he was the one that I got the quote from of "You're not special." That again, I think that it sounds like the findings we have had are very similar. And the scope and nature, again, I say the number 85 and I cringe a little bit in full transparency, but it is my understanding that that's as a nation from a care hospital perspective where we collectively are at right now.
Well, thank you. And you're all special for all the right reasons as far as we're concerned. And, you know, I know how stressful it is when the Joint Commission comes. It's just everyone runs for cover. And I know how picky they are and how specific they are and how it gets down to whether you're wearing the right scrub top and the right shoes. And it's just very hard to have an institution with this many patients, this many staff, and end up with these few numbers of citations, all of which, as you said, with very few have really risen to the level of concern. So thank you so much and great work. And sorry you had to go through all that.
Thank you.
Thank you. Could you go back to the last slide, which showed the different not from your presentation, but from your response in terms of the number of citations. And just keep going until we get to the ones that showed, you know, the grid, that one. And so the right-hand side is our current report. Is that right? Or the left
Correct.
is?
Correct. The left is 3 years ago. The right is our current report.
Okay. And therefore, just like the grids we've been following for other surveys, the red, of course, is that which needs a response that must be satisfactory, or we would, I mean, what is the jeopardy of those that are in the red, and what is our status right now in terms of being prepared for their return visit in the next few days?
Got it. So the answer is everything requires a response. If they see it, we're required to respond. The significance of the colors. So I will first note that at the top of both of these, you can see they changed it from ITL, which was immediate threat to life, to ITHS, immediate threat to health and safety. So we did not have any measures that ranked in that top category, which is excellent.
Emma, I'm sorry if I may. It's really tiny on our end. Is it possible to enlarge it on your end so that the numbers seem bigger or something? Because it's almost like ants on the ground. That's a little better. Thank you. And I'm sorry to interrupt you.
Thank
no,
you.
You're fine. Please. Let me see if here I can kind of. There we go. Get kind of the.
Yeah.
Is that better? Okay, good. Sorry about that. So what I will say is that there's nothing in that top red column in either 2021 on the left or this year on the right. which is excellent. One of the major things to note for the commissioners is that anything that is in the red or like the darker orange, they have a cutoff. But for those items, we are required to write additional responses to both leadership involvement. So essentially what Joint Commission is looking for is how has the executive team been engaged in the fixes and kind of engaged in the work and preventing it from happening again. Because the second piece that we have to respond to is a preventive analysis, where essentially we're looking at this from kind of an RCA perspective of how did we get to this finding and how are we going to prevent it from happening again. So they actually want to know that additional information for those most significant findings. In terms of where we're at and how prepared we are, I think we have done a considerable amount of work in the last month. There's approximately out of the findings. So whether or not they're coming back is dependent on which findings tie back to a specific condition level of condition of participation, so CMS. And so the findings that we were cited on that they'll be returning for all relate up to an infection control condition of participation. And for the most part, we are in very strong shape. I think in full transparency, there are a handful of those things, including a single expired hand sanitizer and 2 individually wrapped bleach wipes and some dust that are included within those findings. And so there is a piece that we have been doing at this point daily rounds this week. We've been rounding all for the last month. We did a scavenger hunt. We've done all kinds of things to try to collect everything, but there certainly is an element of that, of just trying to ensure that we have done absolutely everything possible. And so I would just take a moment to say a special thanks to the team that I currently have, because they have really come together in the last month to kind of rise to the challenge.
So if we're looking on the right-hand side there, one shows up, which is the one that was also cited back in the previous survey. But were there different circumstances or that is different issues that were cited 3 years ago as versus this new one, even though it's under the same number rubric?
Yes, so it is one of the most common citations. It also, 80% of the citations that do happen under that immediate threat to health and safety are of this nature. So these standards relate to high-level disinfection, and it is something that the Joint Commission has focused on significantly for the last 5 to 10 years. It is, I think, relatively easy to quantify in the sense you can walk into a room, ask for the manufacturer's instructions for use, and then go through them with a fine-tooth comb. It's very black and white in that nature. And so what I will say is that they are different findings, but they are similar findings. So some of the findings in 2021 included that there was tape on some Mayo stands as well as some instrumentation issues, and we did not have those issues this time. Again, the focus of the issues this time predominantly were related to one item that was not being high-level disinfected for respiratory care, as well as the TEE processing. There was one similar issue about using low-lid cloths versus paper towels on ultrasound probes, but I believe that is well in hand to all areas that use that process. But overall, it's a similar related issue. And if I had to make a prediction about what our 2027 finding safer matrix would look like, I would say there's a reasonably high likelihood that it hopefully would be out of this box, but that this ICO 20201 EP2 would appear somewhere, just given the wide-ranging piece about infection control and the focus that Joint Commission really has placed on it from every survey and every hospital.
So my final question comes actually from the historical background for the Health Commission, which actually arose when SF General almost lost its accreditation 20 some odd years ago. And so how confident are you with this type of scorecard that we will be accredited?
Sure. So what it really comes down to is this next visit. So they will be coming out. We've been telling collectively, we were predicting 2 surveyors for 2 days, though it could be as little as 1 surveyor for 1 day, or they could decide to send an entire team. They will be looking at those 20 findings. And then again, they will also be looking if they see, you know, on the way to the room with the high level disinfection, they see a crash cart that the log hasn't been checked. They will also cite us for that. Again, the team has done a considerable amount of work. To some degree, it is going to come, full transparency, it is going to come down to surveyor preference in the sense that, you know, if they are looking to the letter of the law of your corner of your glove touched something, that there is a certain amount of uncertainty. I think that would be, I would never lie to you, and there is a piece of that. But what I will say is every day for the past month and 10 days, the group collectively has been working to address each and every one of these findings. I believe we will be accredited in the near future. I think I'm very, very hopeful that it will be with this next visit. In the event that we are not able to get the condition level findings rolled back down during the next visit, then there would be a third and final visit by Joint Commission before they were to turn us over to CMS. I was present on the regulatory team in 2017 when we did get to that point due to ligature issues. So again, I'm very hopeful that we don't have to go any further down this path, because the deeper down you get in the hole, the harder it is to climb out. But I think that's the best degree of certainty that I would say I can give right now.
Well, thank you. And I believe that it would be very appropriate that we be kept in touch and that our officers be immediately notified if there is any chance that we may have problems with the survey. We wouldn't want to get into a situation again where we'll have to try to figure out exactly how to maintain our accreditation. The scorecard looks like we should do okay, but as I think you noted that the surveyor has a wide amount of discretion, and so much often depends upon the individual surveyor. So we will hope that your prediction is correct and that this will be the final time we'll see them for 3 years. But please let us know as soon as you find anything that seems to be going awry. So,
absolutely, will do. Thank you, Commissioner Chow.
Thank you very much. We'll go on to the next item, please.
Sure. Item 5 is the CEO report.
I just want to take a moment to give Emma Moore and the regulatory team a huge shout out. They are managing a lot right now. The reason Emma isn't here is because we have CDPH on site, same with Adrian for that matter. We're expecting the Joint Commission. We have a Commission on Cancer survey on Thursday. We're in the window for the lab. It is just a lot. And I cannot imagine having a better, more well-prepared, more supportive regulatory team. So yes, it is surveyor dependent, but I can't imagine any better preparation for their visit. And as we always do, we will let you know what is happening, whether good or bad. So yeah, we can keep you in the loop.
Thank you. And I think the commission understands and has noted the very hard work and the amount of in-depth information that we've been able to get even to our questions so quickly. So our thanks to the team also.
The way those standards roll off Emma's tongue is really impressive. Okay, so I'm going to introduce you to our report. We have a lot of news this month in addition to the data. It's really nice to see the funding from the foundation rolling through to support our work. In this case, in predictive analytics and the Children's Health Center Healthy Steps program. You can see the all that we celebrated this past month with Black History Month and Lunar New Year. We had visitors ranging from high school students to a team literally from Finland. I had a chance to meet with them. That was very exciting. Most importantly, I would say I want to just stop and welcome our new leaders. You've seen them before, but we wanted to officially do so in the report. So first of all, Dr. Ortiz, sitting right behind me, and Dr. Chow, he will only be the CMO. We have a period of time where he is juggling both the chief of staff roles and the CMO roles, but the selection for the chief of staff goes through a process that you're well familiar with, that is stated in the bylaws, and that's already started. So we will get as quickly as possible to a single role. But he's very busy and very effective, and just thrilled to have him as our chief of staff. Our chief financial officer, Eric Wu, is right there behind me. He has been our director of budget and decision support, and he has been ZSFG's finance equity champion. And his appointment to this job was heralded by all at ZSFG because he is well known and loved, and he's been a really effective partner in all that he does. And then last but not least, we wanted to call out actually an interim appointment, Chauncey Jackson. He has been appointed as the inaugural interim ZSFG deputy COO. And these changes, the changes in the COO structure were made before Andrea Turner left. This is really important, mainly because our director of facilities and capital, Terry Saltz, is retiring. And we had an incredible opportunity that was facilitated by our finance and HR team to actually appoint somebody to a role before a person left, so we could transfer the considerable knowledge that lies only in Terry Saltz's head about capital programs and facilities. So that handoff is happening now, and we're going to first hire our chief operating officer. That recruitment is happening now. Actually, the recruitment is open now. And then that person will select the permanent deputy COO. And the deputy COO will have purview over facilities and capital along with other things. So lots of transitions, but incredible opportunities to bring in very talented and outstanding people who are here. I had the most fun ever celebrating our heroes at the Heroes and Hearts Award ceremony this past month. Just an incredible, diverse array of people that we had the opportunity to celebrate. Dr. Andre Campbell, Dr. Hallie Hammer, and our lead chaplain, Claire Bowman. That was a wonderful event, and these folks were very well deserving of that honor. And then I think I'll stop there and see what questions you have about the narrative portion of my report before I go on to the data.
Commissioners, any questions, Commissioner Green?
Well, I just wanted to say how amazing it is that you keep coming up with these talented, committed, dedicated people. And I think it's a testament to the leadership team and just the culture at the general, coming from a different culture. And I think I've said it before, you are just exemplary. And I think many, many people would want to work on your team and work at the hospital, despite the challenges, for the very reason that the culture is so terrific and so thoughtful and so equity based. So it's wonderful that this wellstream of excellence will continue.
Thank you. We really appreciate your very kind words, and we work hard and we have fun. So we'll keep bringing in the talent.
Yeah, I really enjoy the pictures you have for the Lunar New Year, especially the fact that you have the lions there also.
Yes,
in glorious color.
Yes, the Lion Dance is a really fun event, and you know, we had to pause during the pandemic, and so this was the first year we brought the Lion Dancers back, and we had to find just the right place to locate them, and we did, and it's a lot of fun.
Well, thank you. Let's and again, I would say that we seem to really develop leaders, and then they all go on to bigger and better things or retire. And yet, as Commissioner Green pointed out, we're able to find talent to fill that. and really appreciate the efforts that our CEO does over there in order to do that, because it just can't happen. So you have to develop these people. So thank you very much.
Obviously, you're a magnet, so because it is incredible. Oh, this amazing, stunning person is leaving, and then oh, this new
Here's
amazing,
another
stunning person is here. So
I think Brant joked that I was running a finishing school for healthcare executives. I don't know about that, but
Well, he's actually a graduate at that school. I mean, it's been something I think this department has been doing for years.
well,
Yeah.
you know, it is true. ZSFG has been around for 150 years, and I feel like you know, we all are caretakers of this incredible place, because there have been outstanding leaders for all of that time, and there will continue to be. So we take our responsibility and that stewardship really seriously.
So let's go on to the data.
Okay, the data, the fun stuff. So the emergency department is busy. You can see this slow and steady rise that we've seen since the pandemic. It is, some days the volume goes well over 200, which is a lot to manage, but we do. And then you can see also the daily admissions from the emergency department follow. You know, we've had a very stable percentage of emergency department volume that gets submitted. It's about 15-20%, so that the two track together. I'm very proud of this next graph, which shows our leave without being seen and leave without being triaged rate. And you can see that we've really had a nice movement down. And this is not by chance. And I've described this work to you before, but this was the very first value stream that we did following the pandemic. It involves the daily focused work of everyone in the ED, including the patients, from whom we get feedback through the text surveys that we send them. So given the volume especially, and given how busy that triage area is, because remember, most of the patients coming to the ED walk in. They don't come in by ambulance. So getting the patients to the right care and the right person at the right time is really hard, and they've done a fantastic job. And then diversion, we're doing a lot better as well. We had, I would say, a predictable increase. January is always a really hard month for us, and you can see that it went up to almost 70%, which was similar to what we experienced last winter. But February was 47.6, and March to date is even lower than that. We're at 41.9. So in spite of the volumes, in spite of the boarding, in spite of, you know, a lot of the flow issues we have, we are able to keep that diversion rate down. And in the past, you know, our best understanding of the two major root causes have been staffing issues and boarding. So the staffing is much better. There's no doubt about that. The boarding we still struggle with, but we're doing pretty well in spite of that. Urgent care is pretty steady. And the transfers from the emergency department to urgent care are steady at a fairly high rate. Urgent care does a great job with accommodating the appropriate patients from the ED. We still have this rise from urgent care back to the ED. We don't really understand what's happening here, but the team is diving into it. We weren't sure last month if it was a blip that had gone up, but now we see it's not a blip. So we'll be working on getting you a better explanation for that. The next slide I want to focus on is the average daily admissions to inpatient psych from PES. And as long as that line is going up, it's a good thing. It means that we have movement out of the acute psychiatric units so we can move people in from PES. These are small changes because the overall rate of admission from PES is pretty low. In general, there's a low percentage of patients that get admitted. Most people are discharged. So it's a small change, but it does connote better flow, which is great. Moving on to medical surgical average daily census. I looked at this number and I kind of scratched my head a little bit because you can see the number is slightly lower, but it doesn't really feel that way in the hospital. It still feels extremely full, and you can see that we're operating above our budgeted beds by a considerable percentage. We'll talk a little bit more about why it's still up. The ICU is down, and that is also predictable. We have peaked over the winter spike, and so now we're running at a much more calm census than we typically do in the winter. Maternal child health is pretty stable. It goes up and down, as is acute psychiatry. 4A is steady. I just want to say in advance that you're going to see a drop in the next month. And the reason for that is the seismic work that we're doing on 4A. So the census, and you know how much we need those beds, the 30 beds. But the census, I think now we planned for 28. It might go a little bit lower than that. It's very challenging to do that work in the unit because it's loud. The type of work that they're doing for the seismic work involves saw cutting of concrete. And so mitigating the noise for the residents is really challenging, but the team is doing a great job. They have a room across the hall where patients can go. They've timed the work. I think it's from 8 to 4, so they're not bothering people while they're sleeping. So they're working really hard on mitigating that noise. And then we have our lower level of care, which is still, we're struggling. If you look at the med-surg lower level of care average daily census, if you add the numbers of the decertified administrative days, the first, in March of 22, those two numbers add to 48. In February of 24, we're at 76. It's a really, really tough problem. Our Department of Care Coordination teams, our med-surg teams, they do everything they can to try to facilitate movement out of the hospital. But a lot of it is things that we don't control. About half of the volume is skilled nursing facility. And we are working very hard with a health plan to try to help us facilitate movement out. And then there's the other half is a lot of other things. Behavioral beds, residential beds, going home, just not being able to get the equipment and other things that people need. So we're still working on it. The 4A chart is a little bit confusing. It's not structured in the same way the med-surg chart is. The darker line on the bottom are the custodial patients, which are very few. This just shows the skilled nursing volume. So we're not worried about what is happening there in the same way. And then the acute psychiatric issue is really not that different. The numbers in the first year are 36. In 24, it's 39. So that's a problem that goes back many years. And we work very closely with behavioral health services on that. COVID, I think we have one COVID patient in the hospital today. It's the least of the things that we're worried about right now. I'll just end with the workplace violence activity. I'm so proud of the work that we do. We still have assaults and assaults with injury, which of course we are working to eliminate, but you can see a really nice trend down in all types of assaults, both verbal and physical, which is what we're working on. And we've talked about that a lot in the past. I think I'll stop there and see what questions you have.
Thank you. Commissioner Christian?
So thank you for, this is so clear. So thank you for that. But, you know, what you've been able to do with the Leave Without Being Seen, can you just describe a little bit about the strategies that you've come up with that have been so successful?
Well, a lot of it has to do, it's multifaceted. And, you know, there are things like meeting patient expectations. Like we have a charging station for people's phones in there. We posted a board where patients know how long they're going to wait. But in terms of it, some of it has to do with staffing. And when physicians, you know, putting physicians in that area, making sure we have advanced practice nurses in that area, having a team lead. So it's working with the staff that we have in the emergency department to make sure that we have the right people when the volume is high there. So we can see the patients, assess them effectively, and then get them to the right place. And the right place is either discharged, transferred over to urgent care, seen in the back, or rarely into the more acute areas of the emergency department. So it's really about using the resources we have as effectively as we need to make sure that people get seen quickly. Because when we see people quicker, they're less likely to leave. So that's I think that's overall.
Smart management and,
Yeah.
you know, looking
As smart as we
looking
can
for,
be.
yeah, looking for
Yes.
opportunities. And this is something that you know, probably can't answer at all, but I'll ask it anyway. Now that Prop 1 seems to have passed, do you think any of the problems, the issues, the challenges that we and everybody else sees about not having enough beds and psychiatric beds, things like that, might in 10 years be addressed? Or do you think any of that money will help?
I sure hope so. I mean, as you know, we have a challenge with beds, and the beds that we have the most challenge with are state hospital beds and locked psychiatric beds. And hopefully Prop 1 will make resources available for those things. But beds take a long time.
Mm-hmm.
And it's not just building the beds, it's staffing them.
Mm-hmm.
And there are challenges with that. So, you know, it's great news that Prop 1 passed. We're hoping it helps, but we're not expecting any help anytime real soon from that particular thing.
I can only hope that the state and locally here that we can be as successful in thinking about ways to bring resources to that aren't obvious to address some of the deficits that we have just along the way here and there. I mean, just an example, what you've done and the way you approached the Leave Without Being Seen situation. There have to be ways that our community and our policymakers can look around and find ways to support bringing more healthcare workers and supporting them being able to stay in the city and, or at least somebody nearby and be able to survive here. So,
well, we work really closely with behavioral health services and the department to make sure that with the resources we have and we have control of and that we have control of getting, we're using them as effectively as we can.
Sure you are. Thank you so much.
Thank you. Commissioner Green, questions? Once again, it's very clear. You know, one of the thoughts, and I'm sure you're looking at this within the urgent care return to the well, not return, but sending to the emergency room is, of course, within the triage. And would you think that by next meeting we're going to have an explanation on that?
I will.
And I was thinking also that and this is sort of a longer term thing, that in terms of our discussion on psychiatry and the need to look into those. Well, now you started being able to admit, that's nice, but perhaps it would be nice to understand the flow, especially for Commissioner Christensen. And in fact, it'd be nice if she was able, actually, I just found out she hadn't actually seen either of our hospitals due to the pandemic. And we were just thinking that the one thing that doesn't move on these charts are the whole PES issue and all. And it would be good, maybe you can work with our secretary in order to perhaps do a presentation in regards to the flow issues.
We've
that
already
we
started
see.
working on scheduling that.
Oh, good.
And there's no substitute for seeing.
Yeah, I
Yes.
can't wait.
And
I'm really,
I tour people through the hospital just about every week, at least once. So I'd be delighted to bring any of you there.
Okay, well,
definitely want to take you up on that. I know you're busy, but it will help me.
It's always fun because then I get to show off all the great people who work in these spaces.
well, it's really important, I think, to see the campus, especially as you're sitting on our JCC. And when you look at the pictures as to where, say, the family units are and so forth, I mean, just to see all of this squeezed into our small little space, it's just amazing.
And to be able to walk through and sit in the space and see what goes on and,
Yeah, it's never dull.
So I'm hoping our executive secretary will be able to help arrange.
Oh,
that.
he's been on it. He's,
Oh, yeah, it's okay.
Yes,
All right,
thank you.
thank you. Let's move on to our next. Item.
Sure. Item 6 is the update on Hoshin and True North scorecard, and I will pull up the presentation.
Yeah, okay. Hello again, commissioners. I'm going to kick this off very briefly. We're very excited to bring our Hoshin back to you. As we talked about the last time we showed you our scorecard, this presentation is representing our work to hone and refine our strategies. So you're seeing a shift in the strategies that we've been presenting to you over the last year. And it's really in our pursuit of being the best hospital and achieving our mission and vision. You're first going to hear from our Kaizen Promotion Office leaders, Hemel Kanzaria and Chris Ross, about the strategic plan and the process we have for deploying our strategies. And then each of our executive owners will talk about the 5 strategies and where we are, how we got to where we are, which responds to some of the questions that you asked, and where we are right now. I just want to briefly talk about our equity, the equity strategy on our scorecard. That work remains in our PIPS committee, and it's going incredibly well. We are still in the green in that strategy. It's really become fully operationalized at the hospital. So I will hand it over now to Hemel and Chris, and we'll carry on with our strategic True North.
And please just let me know when you need the next slide.
Thanks so much. Good afternoon, commissioners. How are you all?
Good, how are you?
I'm very excited to present an update on our strategic planning and deployment process. While this is constantly iterative and we're sort of always studying it and adjusting it, we did have an opportunity last fall to work with the executive team and others through a series of really structured sessions around strategic planning and deployment. And this was the first time that I had a chance to participate in this process. And I'm really grateful to have the partnership of Chris Ross and Dr. Will Hewen on this, who are really 2 of our amazing leaders in this work, and actually both received certification in strategic planning and deployment recently from an external agency. So I'm excited to provide a summary of our strategic process and also highlight some of our vision for 2024 and beyond. We can go to the next slide. So I wanted to also just level set some of the terminology we use that I think you've heard some of which, but just to briefly go over it. Hoshin is essentially strategic planning and deployment. The incubator is a tool that we use as we think about new initiatives and ensure that we've engaged appropriate stakeholders and that they're appropriately resourced to be successful. Flow in this situation is really the idea of constantly studying our strategy. So we've moved away from having a one-day, 8-hour session and sort of figure it out on that day to constantly revisiting the process, iterating it, making sure that we're accounting for all of new information and ensuring that we can move forward using data to drive our initiatives. Key performance indicators, or KPIs, are the metrics that we track on a yearly basis to allow us to move forward and know if we're having success. Whereas the True North outcomes are really metrics that we're tracking over 3 to 5 years to get at our long-term sort of goals. And then finally, Catchball is a process for sort of structured feedback and stakeholder engagement that we employ in all of our strategic A3s and all of our A3s across the organization. We can go to the next slide. Thank you. So this is our True North triangle, and I know that you all are quite familiar with this, but just to highlight that patients and community are always at the forefront of what we do. They are at the top of the pyramid for a reason. It's our why behind why we're here, and we're always striving to serve our patients and our community. And that sentiment is really embedded throughout our strategic planning process. Below that, you see the mission, vision, the values that we employ, and all of which is supported by our ZSFG way, which is our improvement philosophy of aligning, enabling, and improving. So enabling our people and then driving continuous improvement, but strategic work comes out of alignment, and that's how we use this work to align across our staff, across the department, with our community partners. So this is a really important part of what we do. And then on the Next slide, this is a high-level depiction of the structured process that we use. It's a 7-step process that Chris is going to go into more detail with, but I want to highlight sort of how systematic it is and how structured it is. In November of last year, I mentioned that we had a series of sessions where we sort of revisited steps 1 and 2 and sort of re-looked at and considered our true north, considered where we are with our outcomes, with our KPIs, and took time to reflect on where we had had success and where we have opportunities for improvement and how we can account for, those opportunities to drive further improvement. Through that, we recognized, for example, the need for increased focus on workplace experience. And so we have a new strategic initiative that's actually going through that incubator now. It's sort of on step 3 of that process that we're coming back to JCC next month and you'll get a deep dive into that. But that is going through that process currently. We also had the chance to revisit some of our existing strategies. And so you'll hear some of that today, where for our flow strategy, we have new and additional KPIs. And for our patient safety strategy, we have some revisions related, as you'll see, to sepsis. So I think with that, I'm going to turn it over to Chris to walk you through some of the details of this process, but appreciate your time today and happy to answer any questions.
Okay, hello, commissioners. I'm Chris Ross. I'm the Strategic Planning Manager in the Kaizen Promotion Office. I'm going to walk through our 7 steps here and share some highlights from the past fiscal year. So go to the next slide. Oh, yes, perfect. So as Dr. Kazaria mentioned, in the fall, we held a study adjust session to really reflect on our past year's performance and what adjustments we need to make, what pivots for the next coming year. So our first step here is really ground ourselves in our true north and our mission. We do this by conducting an internal and external scan of our environment and our alignment to our true north and our mission. Internally, this is where we incorporate our patient and staff voice, try to understand their experiences, their perspectives, and what do we need to take in consideration as we set forth our strategic plan for the next year. Externally, we look at how we're aligning to DPH and network priorities and how can we strengthen that alignment. We pair this qualitative information with a quantitative study of our scorecard and our performance from the past year. So again, where do we have successes? Where are there still opportunities as it relates to our true north KPIs from the previous year? Using all of this information, the executive team distills this down to a series of goals and targets for the next calendar year. This includes adjustments to our current KPIs, inclusion of new KPIs, or retiring some of those efforts that we found success in. So we'll talk about it in a little bit. As you can see at the bottom, we have 4 strategic initiatives for this coming year. Next slide, please, Mark. All right, the next step here, the next 2 steps, once we have a series of targets and goals established, it's time to start drafting and developing our strategic A3s. So we do this through what we call a catchball in our A3 thinking process. So we put together a problem statement and try to dig into what are those root causes, what are those things that are holding us back from achieving this target or goal, and then go through a series of catchball sessions to engage our operational leads or stakeholders that have a key hand in implementing some of these initiatives. So as you can see here, the picture is an example of our expanded exec committee catchballing our workplace violence A3. These are some of our leaders from our psychiatry department. I'm trying to get their input and their fingerprints around the strategic initiative, incorporate their ideas on how we can best support their teams. Following that, once we have our A3 developed, we've catchball with the appropriate stakeholders and again, got all the different levels of input and fingerprints we can, we begin to operationalize and implement. In this step, we set up cross-functional teams and put forth some of those project management tools, project plan, Gantt charts, to really chart out how are we going to take these countermeasures and initiatives and roll them out throughout the organization. So the example here is how our Workplace Violence Prevention Committee has been structured to support our operational teams, our SALT governance team, and how that trickles down and supports our local units, such as psych, urgent care, emergency department. Next slide, please. Then the final three steps here, all happen in this continuous cycle, as Dr. Casaria mentioned. Supporting continuous PDSA, so taking those initiatives and those countermeasures and helping our local units and local departments take that work and implement it. Implement it in a way where it's able to track and visualize, and tools to engage staff around the performance and to get their input. So one example here that Dr. Ehrlich called out was the efforts in the emergency department led by Dr. Peabody to value stream map the patient's journey from arrival to the emergency department through triage, and looks to call out what opportunities there are in the triage process, engaging staff throughout to understand what ideas they have, where are they struggling. Culminated that with a improvement workshop. The value stream map and improvement workshops were some of our first workshops since the COVID-19 pandemic. And as you can see in the data, they have found success in reducing the left without being seen rate. A key component in this last section of steps here is the visual management being data-driven. So being able to take these high-level KPIs on our scorecard and distilling them down to measurables that are informational, and tools that we can use to track our performance and be able to call out, again, where we've had success and where are there still gaps that we need to address. So another example from the emergency department, Dr. Peabody is leading one of their improvement huddles and highlighting just the progress we've made around the left without being seen rate. And they summarize that in a newsletter that they send out, shouting out staff, encouraging further input from staff, as well as highlighting their overall performance. Next slide, please. So this visual management process happens at all levels over the organization. I just highlighted one example from the emergency department, but kind of bumping that up a level and looking globally, one example is our harm dashboard. So we have various harm patient safety metrics that units throughout the hospital are working on. We summarize that globally to look at trends across the entire campus. And this is managed by the exec team. So at each level of the organization, we're looking at this data, monitoring it, looking for trends, highlighting success. And one example to call out here is the exec strategy huddle, where before the exec committee meeting twice a month, the exec team huddles to review the progress on our KPIs, to cross-share, celebrate success again, and then call out where there's opportunity support across the exec team. So kind of bottom up, top down support. All levels of the organization are tracking these metrics and having these discussions. So that is our process. And I will now, on the next slide, highlight what our 4 strategic initiatives are going through this. This is kind of the result of that. And we'll have our exec owner share a little bit around some of our KPIs and our performance so far this year. So these should look very familiar to last year. They're pretty much our same 4 strategies. There have just been some tweaks in some of the key performance indicators. We've retired some and we've added some new ones. So our first strategy is around optimizing our revenue cycle. We have a strategy on harmonizing and synergizing access and flow across our entire campus. We have a strategy around achieving safe and equitable patient care. And then finally, a strategy on achieving safe and equitable staff experience. So with next slide, just to share a little bit on the next steps for kind of this process, each of our strategic A3s will come to you all commissioners to share updates. We'll do a deeper dive into each of those strategies throughout the rest of the year. And then quarterly, with our next session being in June, we'll bring our scorecard to show, again, globally our performance across all of our metrics. So with that, I will invite Dr. Ehrlich back up to kick us off with the scorecard.
As mentioned, my area here is departments driving equity. And the work that we do here is really carried out in our PIPS committee. It's a very extensive coaching and review process to see that departments are selecting equity drivers in their quality improvement. And you can see here that we are on target and in the green. So that work is proceeding quite well. And we're going to carry on doing it in the same way that we have for now. So I'm going to ask, let's see, Adrian, you're prepping for Adrian? Yeah, right.
Good afternoon, Commissioners. Gabe Ortiz, CMO. So I have the privilege of presenting Safe and Equitable Care Strategic Initiatives. This is work that I've been partnering with Adrian as executive sponsors for the work. Our KPIs, you'll see, have been slightly adjusted from our last scorecard. So you'll notice that we are continuing to work on falls, continuing to work on reportable pressure injuries, and we are adding compliance with the sepsis bundle as a new initiative that appears at the top of the Safe and Equitable Patient Care section of our scorecard. We are moving colon surgical site infections, central line associated bloodstream infections, and catheter associated UTIs to watch metrics at the executive level, maintaining those as driver metrics at the within the unit or operational areas that are driving that work. There are some pretty mature teams there that are continuing to focus on initiatives to maintain the rates and actually continue to improve those rates. If at any point those metrics, those watch metrics trend in the wrong direction, we would kind of elevate those back to drivers. And kind of, I'll explain some of the rationale for elevating this new elements, the sepsis bundle compliance, and some of the rationale behind elevating that as a new driver. In terms of our performance, so our HAPI rates, our target is 0.2, and we are at 0.19, which is a tribute to the teams that have been driving this work, very interdisciplinary work across the organization, kind of top to bottom, looking at the workflow and identifying from how we manage linens to do our assessments and skincare to kind of how we maintain our beds, and kind of how we engage with our wound care nurse specialists. Really just outstanding work by the teams to bring those down. We want to continue to focus on that to make sure their work is sustained, since this is one of our newer drivers, to make sure that the improvements that we're seeing are maintained. In terms of falls with injury, you'll see that our target rate is 0.45, and we're still above our target rate at 0.67. A lot of work is going on towards kind of driving standard work for implementing best practices for falls prevention and exploring other potential interventions that might help kind of tailor to the care area that experiencing the falls, and the patients experiencing the falls. And then I'll talk a little bit about sepsis. Our current performance with this particular metric is 38% compliance, which is below the CMS 50th percentile, which is 57% compliance. And so given the opportunity there for big improvements, given how this aligns with our CMS star rating, we've added this and elevated this as a new driver metric to try and help the organization achieve better care as well as drive our CMS star rating. In terms of successes and challenges within the past 3 months, one great success, as I alluded to, have been the integration of the HAPI workflows, or kind of skin rounds, and kind of standard work best practices in terms of the management of linens and turning patients and kind of skin assessments, kind of really dramatically turning around our HAPI rates. I think kind of in the ICU, it's been over 12 months with 0 HAPIs, and just a remarkable achievement by the teams that have been driving this work. One challenge, the kind of falls continues to be a challenge. While the rate is relatively flat, it's been hard to drive the rate downwards. There are a lot of idiosyncratic findings sometimes that are very patient specific, that are hard to come up with structural change to help drive falls prevention. But we continue to kind of challenge ourselves to try to find things that might really transform our ability to keep patients safe from these fall events. One PDSA planned within the next 3 months is given our new driver metric with kind of bundle compliance for sepsis care. We are going to be standing up a task force centered around the emergency department, where a lot of our septic patients initially present to our organization, and then develop our key performance indicators specific to this driver metric. I'll take a little bit of time to answer some of the questions that we received, kind of in terms of how the goals that we have for our safe and equitable care metric, how do they compare to the Casper data? I think this is a really important question in terms of how we benchmark the work that we're doing at our organization and kind of compare to what's happening across the country. Casper is more specific to long-term care. So the benchmarks that we kind of use to drive the drivers here are really the CMS star rating, 50th percentile, which I alluded to. That's kind of where we set our target for the sepsis bundle compliance, wherever that is available, if it's kind of a rating that is included within the CMS star rating. For elements like catheter-associated UTI, colon, surgical site infection, and central line associated bloodstream infection that may not be within that kind of benchmarking. Excuse me, for things like outside, like falls and HAPI that are maybe outside the CMS star rating, we turn towards Leapfrog, the IHI, HRQ, and other benchmarking organizations, as well as our own past trends to determine our baseline and then an appropriate target for the metric. So we try to use the evidence and whatever data is available to kind of help define where what we aim for in terms of targets for the organization. I mentioned a little bit about some of the rationale around why the sepsis bundle has been elevated to a driver. And then kind of in terms of the specific scoring around sepsis bundle compliance, the KPIs, we're really going to lean on the teams to do a current state analysis to see where it is that we're falling short, which parts of our workflows are creating the vulnerability and kind of not meeting the bundle compliance. This element really is multifaceted. It includes early assessment, drawing diagnostic tests like blood cultures, and then intervening within kind of a 3-hour period with kind of antibiotics, fluids, and other interventions, and then reassessments. And so we're going to turn to our sepsis task force to identify which elements within the bundles we're falling short on, where that's happening, and then kind of that will help kind of define or determine some of the KPIs that we drive on. The 57% target for that bundle compliance, again, comes from the 50th percentile in the CMS star rating. And so kind of aiming for that the 50th percentile as a target for the organization, up from 38 where we are at baseline. And I'll stop there and take questions on the safe and equitable care strategic initiative.
Question?
Yes, thank you for explaining the way the various parameters have been moving. I think it would be very helpful for us if you can possibly give us context of the rates that these other organizations are using for these various items, because I know you hold very high standards for yourselves, and it would be very interesting to see, what the norms are, and also how many similar hospitals are achieving them, because I think some of them are set unrealistically high depending on the population you're caring for. So that I think would be helpful to know. The other question I have is with Epic. I know we have sepsis protocols, and they're kind of off the shelf with Epic. I use it all the time for choreo and for endometritis, and I believe that I was just going to cheat in my look in Epic here under orders and see what's in Haiku, but I know they're out there, and so I'm wondering what you can utilize off the shelf that is already available in Epic.
Yeah, great question. For this kind of first part of the question in terms of the benchmarking, I can look into kind of what goes into the different organizations in terms of that median target that we're shooting for at 57%, and why kind of the median is 57%. I would say remembering kind of looking at bundle compliance way back in the past many years ago, our sepsis mortality is actually pretty good. So there's questions around how these elements contribute to ultimately to patient outcomes. I would say that kind of best practices are best practices, and kind of there are reasons for some of the resuscitation elements and other things, and also ruling in sepsis can be really challenging in terms of SIRS criteria and other things where you get a mixture of patients that maybe were not septic to begin with. However, I'll look into kind of that CMS benchmark a little bit more and kind of determine where potentially other organizations are falling short in terms of a 57% kind of target that we've set for ourselves. In terms of the second question, it's a great question. We're leveraging technology to help standardize the care is a critical and really important approach or strategy to always consider. I think kind of the team has already, before even collecting all of our current state data, kind of looked at our own organization in terms of other best practices for other things like heart failure, which we've touched on before, and the development of care pathways that then standardize different elements and interventions along the patient's progression of care during their kind of encounter with us. And so the team's already thinking about kind of structuring the care interventions in that way to help leverage the electronic health record to then guide the appropriate interventions at the right time. And there may be more things that we explore as we dive deeper in terms of trying to be smart and targeted and kind of judicious around what we're doing for our patients and trying to kind of providing the best care. And so more to come, I think, as that kind of sepsis task force gets stood up and starts to dive a little bit deeper in terms of their analysis of what's happening and potentially different things that we might be able to leverage, like order sets and like care pathways to help structure the care so that there's less variability from one person to the next in terms of how we're managing these conditions.
Thank you. And I don't want to create any extra work. I was just more curious on Cowdy and CLOBZ and all that. CMS says this is the rate you should attain, you should, shoot for. And, Leapfrog says this, if you just had that, I'm just more to understand context.
Yeah.
Thank you.
Yeah. I want to follow on sepsis before we go on to questions from Commissioner Christensen, because I'm having a little problem. The 57% that you're talking about, that really is, is it that CMS has rolled all those up and they want you to have achieved 57% of something?
That's the median of all of the hospitals that are in the CMS database that are reported there. And so kind of we're shooting for hitting that. And if we can get beyond that, that's even better.
Oh, you're trying to see where you are in comparison to the other hospitals.
Yes, that's right.
And currently we're 39% and you want, so that's the reason why you've really changed the numbers. We were previously watching that we wanted these to be lower and then we come to this. And is CMS actually using the combined bundle rather than the individual items for payment?
They're using that bundle as the discriminatory kind of quality metric.
Okay, so the bundle, the quality measure for payment purposes, actually, which is what those little stars are. That we've been following to make sure. So now we've reduced the number of stars from 3 to 1.
On the executive card, at the team level, they're still driving CAUTI, CLABSI, SSI. Those are extremely important for the organization. And if we see that for whatever reason, there's some pretty kind of well-oiled teams, I would say, that are driving that work at kind of the operational level. If we see that they're kind of losing handle of any of those, we can bump it back up to be visible on this scorecard as a driver. And so we'll watch those and kind of support the teams doing that work at the operational level. But in terms of investing kind of a broad kind of executive presence and kind of more targeted initiative in terms of new interventions, hoping to add this one and have some success with this one to help kind of raise the star rating overall.
Oh, okay, great. Commissioner Christensen?
Thank you for asking that. Thank you for asking that question. And so these ratings by CMS are given on an annual basis.
Yeah, annual
Mhm.
basis.
And it affects reimbursement rates.
It does. And kind of publicly reported quality metrics. And so in terms of visible to the population.
And so when the items are in the red, what does that mean for the reimbursement rate? If that's an actual question you can answer. I mean, it just even directionally or.
Hi, this is Adrian. I apologize for not being in the room. I've been able, the surveyors have left and I've been able to join the WebEx. So I think that there's not a straight yes or no answer to this question. Some CMS star ratings are attached to value-based purchasing and some just affect our star rating, which insurers and the public use as a yardstick to whether to choose us as a provider of care. So historically, sepsis had not been attached to value-based purchasing, but it is going to be from 2024 moving forward. So not only does it have a small but nevertheless an effect on our star rating, but it will be also associated with reimbursement. Not all star rating metrics are, and CAUTI, CLABSI, and Cullen SSI were not all included in value-based purchasing, but this year sepsis is being rolled in as one of them.
That's helpful. Thank you.
Thank you.
Chair, may I ask?
Yeah,
With your permission, may I ask a question?
absolutely.
So I really appreciate this, and thank you for the amazing work that the team is doing on this. Just with regard to the sepsis bundle as an example, it's under the Achieving Safe and Equitable Patient Care. And I'm just wondering your thoughts, understanding the numbers may be small, but breaking this down and analyzing it by race ethnicity, because we've seen in other areas of care, hypertension, so forth, that there are discrepancies when you look at patient populations by those different groups.
Yeah, I love that question. I'll bring that back to our team. Thank you for that.
I can speak to it at a very high level right now. I apologize again for not being in the room. But we don't currently stratify our sampled metric by race and ethnicity because it's a sampled metric, so it's not all of the patients. So it would not be representative or an accurate representation of the population that suffers from sepsis. But that will be something that we integrate into our task force work so that we are able to stratify it moving forward.
Great, thank you.
Thank you for bringing that back up too. Really appreciate that. Are you going to continue with several of these others?
Yeah, I would love to continue.
Yeah, your name's
permission. I would love to present the harmonizing and synergizing access and flow across the ZSFG campus. And this really builds on some of what Susan has already discussed in the CEO report. Access and flow is kind of such a critical driver metric for the organization. And what you'll see represented in our drivers, there are two new ones, acknowledging the importance of access and then flow through our different care areas. You'll see ambulance diversion continues to be represented. We currently are performing at 47% diversion. We're aspiring to drop that to 35%. You'll see third next available specialty care appointments, wait times less than 21 days. Out of the percentage of all the clinics we have, we'd like to keep that number high. And so you'll see that we are achieving a 96% rate there of clinics meeting that target, above our goal of 90%. That's a lot of work by our specialty care leaders in adding extra clinic time on kind of evenings and weekends to achieve that. And then you'll see that lower level of care, which has been alluded to, continues to be on the scorecard. This has been a challenge that I kind of will reflect on a little bit. You can see that we're at 1,800 days for the month of February, and we're kind of hoping to bring that down to 1,100 days per month. You'll see two new drivers. The left without being seen, percent of patients that leave without being seen from our emergency room waiting rooms. And you'll see that our target there is 4%, and we are currently at 4.9%. And as Susan alluded to, a lot of interventions in terms of managing our staff, rearranging the way that we do our work, bringing providers up into the kind of the triaging and waiting room areas to initiate the care for our patients earlier. And what I would say for kind of all of these drivers, there's a lot of culture change. The leaders in these areas, it's kind of I think Will and I reflected at a recent committee meeting where we had all of our teams presenting some of their flow work. They're tools, and then they're the people and the culture that kind of use the tools. And this work really represents a lot of culture change in terms of just the importance of kind of serving our patients in an efficient way and trying to get that care started as early as possible. So we're still not at target, but kind of the winter has been very challenging in terms of increased numbers. And so we're hoping that as things kind of stabilize a little bit post-winter, that we'll continue to see even more success with that number. And the other new driver is the add-on case completion in the peri-op area, which is another very important part of our access and flow initiative. And this is kind of currently operating at a 68% completion rate, and we'd like to get that to 95%. And the perioperative leadership team has been working extremely hard. Last time I was here, I presented the surgery department service report, and they are critical partners in some of this work, and hoping that the work that the team does helps in terms of some of the metrics that we looked at within that specific department. The team has been using block times that are unused and kind of creating new standards for kind of reallocating those in a timely way so that that time can be used for some of these add-on patients and kind of get those cases completed, which will also impact the hospital. Many of those patients are in our acute care areas waiting for procedures in order to be able to then be discharged. We're very excited. I think if I were to highlight a success, I would say that our left without being seen and all the work that's been done in the emergency room in terms of waiting room and triage workflows is a tremendous success. Our challenge continues to be lower level of care patient days, or a large number of patients on any given day that are ready to move on to their next place of healing. And kind of we're working with the team to try to understand what's within our control in terms of identifying those patients as early as possible, and then what can we do to advocate for what those patients need in terms of moving out to the community. And then a PDSA that I'll highlight, looking forward to working with the perioperative team. We have a budget proposal that's been submitted for consideration, which would allow us to add an extra operating room every day. That would help tremendously in terms of both backlog of cases from the ambulatory setting, but also this add-on case completion rate. And we'll work with that team to develop kind of what tests of change they may be able to impart with if that budget proposal gets funded, what work we're starting to plan out, what work they may be able to do in order to help meet the needs of our patients in a way that's equitable. I will stop there and open up this initiative to any questions or comments.
Questions?
No question.
Commissioner? Yes.
Yeah, I'm just curious, when you talk about utilization, is there any AI? Are there any AI programs, especially with the operating room? It seems like that might be really amenable.
It's
I mean, they do it with the airlines, right?
It's a great question. There are, lots of, I've seen reports of companies that kind of market products like that kind of help manage operating room block times and kind of create efficiency. I'm not sure if there are any kind of tools out there that have kind of received the stamp of approvals from various at a higher level in terms of I think a lot of things are in pilot or testing phase. But I think it's an important tool to be considering given how these tools can really create great transformation in healthcare processes and sometimes open up unseen opportunities in terms of traditional way of looking at how operating rooms are structured or how block times are scheduled. It is a very complex jigsaw puzzle in terms of getting this service area to kind of function at a very efficient level, and lots of moving pieces. And I think it is kind of ripe for those types of generative AI and other kind of novel approaches. The team is at the early stages of mapping out kind of how they're going to approach the use of that time, if that gets funded, to make maximal impact.
Thank you.
Thank you. Any other questions? No, let's, thank you. This one was clear.
Great. Hi, my name is Angelica Jernigan. I am the Chief Administrative Officer, and I am covering achieving safe and equitable staff experience part of our True North scorecard. So a really emphasis on our workplace violence. So our key performance metrics, KPIs for our 2024 scorecard we're keeping physical assaults with injury, as well as adding a new driver, number of departments reporting a driver for staff engagement at PIPS. The reason really behind this is we had so much success with our equity metric at the top of our True North scorecard, where we used our PIPS committee to really drive the change, because you have the directors of the departments really taking ownership of it. We wanted to do the same for staff engagement, as they're really closest to being able to move that metric forward. Where we're currently at, so having said that, it's a brand new metric. We haven't rolled it out yet, so we don't have any baseline measures, but we will be looking into that. Moving for our physical assaults with injury, as you kind of saw earlier, our target is 4. We're currently at 6. We've had some really great movement in the right direction, and so we were wanting to really just kind of focus and making sure that we're maintaining that work. And so to that point, you'll know that I'm new to this. Andrea Turner used to be here. Myself and Adrian Smith are kind of taking the charge since Andrea has left. And so one of our challenges, I'll start there, is that it's just a transition. So we've been, we're really helpful for Andrea. She took a lot of time debriefing myself and Adrian before we left. Jason Victoriano in the KPO has also done a lot of work to make sure we're brought up to speed. But as you can imagine, with any transition, making sure that nothing falls through the cracks is really kind of the challenge that we're facing right now with this strategy. To that point, though, I will say one of our successes has really been the fact that we have maintained every single meeting. We haven't seen any spikes in our numbers, and we're kind of continuing to engage with all of our department leaders to make sure that we're kind of continuing measures that we've identified. Another success that I really want to highlight is that our CPI trainers, and so our ability to, CPI, we've been waiting for a while to being able to hire those positions, and we have some forward movement there. So CPI, that's our de-escalation training that we want to give to our staff, so that they can put a halt to kind of violent situations or negative situations before they escalate. And so we're going to be bringing 2 of our trainers on staff so that we can start having that training done on a continuous basis and in-house. And then I will say that one countermeasure that we are looking forward to over the next 3 months is really figuring out how we integrate with our staff engagement strategy, now that we're kind of really moving that forward based off of the survey data that we've received. So previously, workplace violence has stood as a standalone strategy. Moving forward, we're going towards saying, okay, workplace violence was such a driver within the larger staff engagement strategy. It makes sense for it to fit underneath the larger staff engagement strategy, staff engagement strategy kind of going forward. So that's kind of where our focus on is. So what we're going to figure out is how do we make sure that we don't lose any of our momentum in here as we kind of work towards integrating with our larger strategy. And then also defining and coming up with a baseline for our driving staff experience, so for our metric. All right, any questions for me?
Commissioner Green?
Yes, well, thank you. And thank you for taking on this incredible responsibility. Where does the BERT team fit into the strategy? I know it's made such an impact. And I'm not even sure if it's fully staffed at this point or how many hours a day they're available. So can you speak to that and how you think that will potentially have a positive effect on the goals?
Yeah, so our BERT team and our BERT leadership, Joan Torres, they are actively involved in our assault governance committee that we currently have, and our workplace violence committee. So they report out every month on kind of how many interactions that they have, like all of their kind of key metrics. And then they're also sitting in the committee with the 5 other leaders. So ED, PES, our behavioral health center, urgent care, and med surge, so that they can also kind of in the meeting interact with them and say, listen to so let me back up and just kind of provide some little bit of context. Our assault governance meetings, the way we work is we have our 5 key areas come and report out every month and kind of just share what's happened and what countermeasures and deep dive into any of physical assaults that's taken place. Our BERT leader sits on that meeting so that she can kind of offer help and solutions to that team, and also being able to quickly identify if she needs to kind of spend a little bit more time in those areas. So our BERT team is pretty well engaged, and we are consistently looking for ways to expand it to other areas.
Commissioner Christian?
Thank you. Good to see you. Thank you for the presentation. Can you elaborate a little bit on the CPI and the de-escalation, and given the stages in which you see patients that escalate, how effective is de-escalation? Can someone actually rationally respond to what the de-escalator is trying to do?
Yeah, so I think de-escalation is actually pretty critical in a lot of healthcare environments, and so it can be it is a very useful tool. So some of the things that it's how to communicate, like some of the training is like how do you communicate with people to not make them to not keep ramping up, right? Because sometimes people get into situations where they're going back and forth, and this gives people the tools to communicate with patients so that they can step back and bring that patient down with them. And then also it provides that kind of training, like if the person keeps on escalating, what kind of tools can you, like where should you go, like who should you involve to kind of like bring the situation back down. So for us, it's really more than anything else, really just about making sure that we're communicating with our patients in a way that they are helpful and they will receive, and that people can kind of know what to do when they're in those situations where they can't kind of move forward.
Thanks.
So, yeah, and to Commissioner Green's point earlier, our BERT team has done a lot of work around de-escalation and working with our staff.
To the extent that it is, feasible, given the work that you're doing every day, when we have our next BERT presentation, it would be helpful to be able to understand a little more deeply how this is working, because obviously having a safe workplace is so fundamental, and given our responsibility for the work, it is really incumbent upon us to understand as much as possible what the thinking is and what the plan is, so that we understand, and what the strategies are, so that we understand the work that everybody knows that you're doing, but that we understand exactly what it is and have a chance to hear more about what the strategies are and why they work and how often they work and things like that.
We can provide maybe a detailed overview of what's included in the CPI training as part of the de-escalation and the communication tools.
And whatever information you have about how the staff feel about the effectiveness of the strategies so far over time, perhaps even.
On that same point of physical assaults, I'm looking at your past scorecard and your current scorecard. What do you feel is the reason that the past scorecard had much lower targets and then we had quite a number of episodes, and even though we have Bert and so forth, and obviously you've reset yourself because the previous year showed that we had a higher baseline, but just wondering what lessons you thought we had learned from.
So one of the, so from my understanding, when we first selected that target, it was based off of data from a previous system that we had. And so when we moved to our SAFE system, it was using essentially better data with a lot more training, with a lot more focus on educating staff, especially in those 5 kind of key priority areas, when and how to report these incidents. So what that resulted in is that we essentially got, I won't say like a completely new data set, but a pretty new data set. And so when we had that, we got that information, we kind of reset our targets for this year based off of kind of a simply more accurate data.
Very good, thank you. And I really do appreciate that we're able to really look at comparison, and I think probably for the first time, we've been able to really see how the progress has gone in terms of the scorecard more easily. And really appreciative of staff who printed it out big enough that we could read them. Thank you.
Well, I will definitely let the team know. Great, thank you.
Next is who? Okay.
Good afternoon, commissioners. My name is Eric Wu. I'm the new CFO for ZSFG. I'm very excited and honored to be presenting before you for the first time. The title of our strategy is Revenue Cycle Optimization, and the KPI is Hospital Billing Denial Rates. Our goal statement is to reduce the percentage of denied claims from primary payers from 18.6% to 17% by December of 2023, and further to 15.6% by July of 2024. We met our December 2023 target with a denial rate of 16.8% and have set a lower goal of 15.6% by the end of this fiscal year. The reason we are focusing on optimizing revenue cycle is so that we can get reimbursed for the care that we provide our patients, so that we can further patient care. Also recently, DPH transitioned from a capitated model to a fee-for-service model. Fee-for-service model, as you might know, requires more robust authorization review and denials management to ensure proper payment for services provided. You'll see on the scorecard that a denial rate for February 2024 was 15.9%. And although this is off our target of our 15.6% target for this half of the fiscal year, this is the lowest denial percentage we have had in the last 12 months and below our December 2023 baseline target, or our target of 17%. So we're definitely trending in the right direction. We're also continuing to advance ongoing PDSAs, such as engaging clinical and operational leaders on denial reduction. Finally, I want to say in the 3 weeks that I've been in this role and after stepping into this role, I'm very grateful to be learning alongside an incredible group of leaders at ZSFG and determining the best way I can support them with our strategic plan. I'll stop there and happy to take any questions.
Thank you, Mr. Wu. Let's see if anyone doesn't understand this. Commissioner Green.
Yeah, I want to make sure I understood. With hospital billing, are there any, I mean, I assume it's your entire service, all your service lines. Are there any that you've identified that are particularly problematical in terms of denials?
That's a great question. So the reason we've sort of set our targets the way that we did is kind of a staggered incremental approach, is that it's going to be a continuous review process for team members as we're looking at some of the issues that come up. As you may know, denials are very complicated and very complex. So as issues come up, the goal is to look at those issues and then figure out what the best way to approach them would be. I don't understand the complexities fully about how the denials, but the team is working incredibly hard to figure out all the issues that drive denied claims for at the hospital.
And the patients that may come in on the trauma service compared to straight Medi-Cal, do you notice any difference in denial rates there?
I do not know off the top of my head, but I'm happy to get you that information.
Well, it's very hard work, I know. Do you have any sense of the lag time between claim submissions and payments? And again, whether there are any certain departments, it is forever. And I'm just curious to know if there are any that are particularly slow to pay. I don't know that much about the way Medi-Cal pays, but if it's anything like Medicare, it's amazing by the time I'm going to get paid, I'll be on Medicare. So I'm just wondering if you have any sense of that.
That's a great question. There is, dependent on the payer, there is a lag time between commercial payers tend to pay quicker than Medicare or Medicaid, but I can get you that time. I don't know it off the top of my head, unfortunately.
No, I don't want to put you to any extra trouble, but when you start thinking about this massive amount of work it's involved in, how do you prioritize and what do you have control over and what do you not have control over? That's a big issue, and how claims are submitted, we probably do have control over, but what they do once they're out the door is a whole other issue. And I assume because it's mainly government pay, you guys have not had any problems with the cyber attack at Change Healthcare.
There were minor impacts as a result of that hack, but they've all been mitigated. We had to do some paper claim processes, download manual PDFs off a website, but most of the issues were very minor and they've all been mitigated. Thank you.
Great, thank you.
Before we go on to Commissioner Christian, just to follow up on the question about the hospital billing denials. Is this the first denial, or you're saying it's after all the appeals that you are counting the denial?
Great question. This is only primary denial. So our rate is based off the first denial that we received.
Okay. And do you know what your rate is after you have appealed? Because quite often appeals are overturned or there is partial additional payment.
That is a great question. Unfortunately, I don't have the answer to that.
Only 3 weeks, that's right.
But happy to get that information for you.
Okay, thank you. Commissioner Christian, and then I'll get back.
Is it following up on that, or, because mine is a little bit following up on that. You've said that the denials are really complicated, and I believe you. And so I'm not asking for any answers right now, but I know one of the things that I would like to understand is what does go into the denials and how much of it is mirrors the concerns that someone seeking, services and seeking reimbursement for those and being denied by their insurance company. Is there any parallel to that situation for the hospitals? Is this care you're giving and then you're not being reimbursed because they said, well, it's not proper, that's not what they were going to pay for, or it wasn't properly documented, or no, we're not going to pay for that expensive thing. We would have paid for this less expensive thing. Not asking for an answer now, just those are the, that's what pops into my mind because that's what's familiar to me. I'd like to, begin when it's time, begin to understand the similarities and the differences.
I'll take that back to the team. Thank you.
I do think Commissioner Christian's point is also because we have a provider group, and are we denied something in which then the provider group, because they have a different payer, is paid for? I've thought about that for a long time because under like Medicare Part B pays, and then meanwhile there's a Part A. And if one is denied but the other is paid, that's sort of a disconnect. But I don't know, because we are, united here, whether that has anything, does that play a role at all where, because there are two different carriers, whether we've ever, come back together and said, well, the surgery was okay, but your pricing is too high and they should have been done over there or something.
Also a great question. I don't have the answer to that, unfortunately.
No, that's fine. It's just something to think about.
But also the feedback about looking at beyond primary payers is a great suggestion, and we'll take that into account as well. Looking at our current denial rate for primary payers, it will also be interesting for us to see what is ultimately paid in terms of.
Sure, because ultimately, and I've seen this in another setting, it's really providers rather than hospitals. There's a large percent that are denied, but more evidence is submitted. And then a significant number are actually paid. And the reason given always is, oh, we got additional information. So then that might be a cause to say, okay, what information should we or could we have submitted that would have avoided a second round?
And that's some of the work the team is doing, as well as we're kind of doing continuous improvement on this sort of claim denials process.
Sure, you can see this is a very important topic for us. Commissioner Green has follow-up questions.
Yeah, you know, in terms of how you set your charge master, if you're going fee for service, because, you know, a lot of these plans, and you've got, as you said, some commercial payers, and they'll pay the lesser of billed charges or their allowables. So I'm wondering, I mean, at least in practice, you try to track percent of collections as a benchmark of how you're doing. So I'm wondering how you're going to how you incorporate that, or how you even set the charge master so that you certainly don't get underpaid because your billed charges fall below their allowables.
I'm going to send you all these questions so that when you have time to get acclimated, that you will be able to respond to the commissioner.
Thank you for the question. Unfortunately, I don't have an answer to that, Commissioner Green.
Well,
Charge master.
Thank you. We work hard for our money.
It's also the state's percent of charges versus real costs. But anyway, I don't know that we have any more questions for you to have to then come
Did
back.
not answer, but I appreciate your time.
I really appreciate your coming, and congratulations again on your new position.
Poor Eric. Okay. I'm going to quickly run through the True North goals at the bottom of the scorecard and then wrap us up and until the next time. So the True North outcome metrics at the bottom, remember, are the ones that we follow over a 3 to 5 year period. We don't expect to see rapid changes in these, and we don't have specific work that's driving improvement. It's all indirect, right? So for example, the CMS star rating, as you well know, is scores of metrics that come together to result in whatever score we get. And the KPIs that we're driving in Select, we select with this CMS star rating in mind. So as you can see, we're green, we have 2 stars, we're very proud of that. Likelihood to recommend hospital to family and friends is an HCAP survey. We get the data on a quarterly basis, and because you can see the baseline, but because we don't have the first quarter yet, we will, the next time we see you, we will fill in the data there. And 77% is over here as the target just because it's 1% higher than our baseline, but we will likely adjust that over time. Likelihood to recommend provider's office to friends and family, we have changed recently in order to incorporate a broader swath of the things that we do on an outpatient basis. So these are real-time surveys, so they're available to us more frequently every month. And we recently adjusted this to include not just clinics, but rehabilitation, outpatient testing or imaging, and outpatient surgery. So we have more data to describe what we do. I'll pause for a minute here to just remark that we have stratified these by race and ethnicity, and it's mainly just to show you the differences. Again, we don't have specific KPIs to drive these here, but we know that the work that we do on our KPIs that you just heard a lot about will eventually change these over time. And so here, because we have the first month's data, you can see that we can show you the difference between the baseline and the first month. And I won't talk more about likelihood to recommend ZSFG as a workplace. You'll hear a lot about that in our next month's meeting. And you can see that our general fund spend not to exceed budgeted amount is in the green for now, which is where we always want it to be. So I'll just close quickly by saying you got a long presentation about this, for the first time with the new scorecard. We will come back to you every quarter. And you will see how we're doing on the various KPIs. Next month, you'll get a special presentation on the staff engagement work, because aside from the workplace violence work, that is new for us, and we want to make sure that you understand our thinking about it. With that, unless there are more questions, I will close out this part of the agenda.
Well, I think this has been a very important and wonderful presentation to really put into perspective now your scorecard, which Remember when it first started, then it changed.
Oh,
and
yes.
Then we now have a track record, which really gives us a feeling as to the amount of work that you're doing in terms of the True North goals. So I appreciate it. And I'll see if my fellow commissioners have any other comments. Commissioner Green, no? Commissioner,
Appreciate it greatly.
okay.
We really appreciate your attention and engagement on this.
Thank you very much.
Thanks, everyone. Item 7 is the hiring and vacancy report.
Good afternoon, commissioners. My name is Emma Perez. I'm with the clinical hiring team in HR operations. And I'm not there presently because I'm getting over a cold, so I didn't want to get anyone sick. And I apologize in advance if I start coughing. Okay, so with the HR report, the total hospital vacancies has increased slightly to 9.18% this month. We have hired a total of 54 employees between February 1st and February 29th, and that includes 5 separations and 2 retirements. Our RN vacancy rate increased to 5%, and we have done a few things to mitigate the vacancy rate, and that is hired some additional P103s. We have continued our onboarding events, which are happening daily. We've moved our fingerprinting to the CHN buildings to facilitate combining the fingerprinting appointments along with the medical appointments closer to the CHN site. And that started back in last week of February, and that continues presently. We continue to have a goal to reduce the DPH-wide RN vacancy rate to 5% by April. And we have a monthly hiring plan in place. So every month we continue a new selection process, and we have a new eligible list that's updated every month so that hiring managers can make their selections. We continue to meet with our program managers and hospital executives on their hiring plans. As you can see, we have less FTE vacancies in the emergency room. We have 9.05, which is 6.54% of RNs in that specialty. They have made quite a number of selections as we try to do this mass hire to bring down the vacancy rate. And so we have individuals targeted to start, well, some already started March 16th, some are starting soon, March 30th, April 13th, April 17th, and May 25th. And some of those are based on candidates requesting a later start work date based on just personal things going on in their lives, or you know, coming from out of state, things like that. The critical care unit has 13.5 FTE vacancies, which is 7.86% of the RNs in that specialty, and they've made 9 selections with target start work dates, again, this month, April and May and June. MedSurg has 11.25 FTE vacancies, which is 3.04% of RNs in that specialty, and they've made quite a number of selections, 42 so far, with target start work dates March 16th, March 30th, and April 13th. The OR doesn't have any vacancies as of the date of that report. And as far as training cohorts, critical care and OR do not have any positions right now for training cohort. So we just have emergency, which is anticipated end of April with a cohort of up to 10, and then another one following in August with another cohort of up to 10. MedSurg is anticipated to have a cohort with staggered start work dates. So as soon as we can onboard them, they'll start them in March, April, and the cohorts are up to 30. As far as non-RN hiring highlights, we have a 1654 accountant that was hired, a 2409 pharmacy technician, 42305 psychiatric techs, 1 2328 nurse practitioner, and one IS 1041 IS engineer assistant. I understand that there were some questions also from Commissioner Green with regards to anticipating vacancies. So as far as anticipating vacancies, we have two types that we can anticipate, which are basically retirements and reassignments. So as soon as a hiring manager is informed of a retirement, they are able to submit a request for a future vacancy so that that process of filling the vacancy starts right away. And again, that's when they're informed of that vacancy, but we also have reassignments, and those we notify the hiring manager of the present supervisor to let them know when a reassignment candidate has been selected so that they could submit a request to fill that vacancy as soon as it becomes available. So we are trying to anticipate those vacancies as much as possible. And I don't know if there's any questions about that itself, but I know there's also questions about how long it takes to get a training program up and running, and I'd be happy to share about that as well.
Thank you. Any questions?
If they had a sudden rash of retirements or service line
you want to
changes,
ask?
how long does it take to get a training
Okay,
program?
well, we can ask.
Yeah, I wonder if you could answer the question about what it takes to get a training program together. If for any reason you did have just a group of retirements, reassignments, and then perhaps some people that just left. If you suddenly had an urgent need, what do you do? It's so great, by the way, that you've filled your positions. I put that in the questions of critical care in the OR. That's fantastic. So, ER is always a big challenge, obviously, but I was just curious to know if you had an unanticipated volume of positions you needed to fill, whether you have almost like an emergency protocol.
Yeah, so thank you for that question. So we do have some of these training programs, as you know, are established, right? So there isn't a need for it to become operationalized because it's already an established program and the hiring managers know already what the content for that training program would be. So it's just a matter of determining for them to identify a cohort start work date, and then we would work backwards from that to try to determine how quickly they would need to make selections in order for the candidates to start by that work date. It usually takes, that can be done rather quickly, but it usually the majority of the time will be in the hiring and an onboarding stage. So I would say it probably would take about 2 months to get them all to start on the same day. But now that we have a very robust training list, the candidates are available as soon as hiring managers are ready to go. We give them access to the eligible list so that they can make their selections for that training cohort. If it were a training program that's not currently established, it would most likely take a little bit longer to operationalize because the hiring managers or subject matter experts would need to come up with the content itself and the logistics for starting a new training program. So it would most likely take anywhere from a couple of months to, I would say, 6 months if that were the case. So I know that that's would take a little bit longer, but again, the majority of our training programs are already established, so it could be up and running rather quickly.
Well, thank you for that answer, and that's actually great news. I really appreciate that.
Absolutely.
Commissioner Christian.
Thank you. Congratulations on the progress. I know it's not been easy. I had a question about the vacancies. The critical care unit says that you have 13.5 FTE vacancies with 9 selections, and so that leaves like 4.5 to fill, if I'm understanding correctly what you're presenting. And then in the next section, it says, next critical care training program will be scheduled when additional positions become available. So it's the way that I'm reading it, which is clearly not correct, is that there are additional around 4 and a half positions that need to be filled, but here it says when additional positions become available. Can you clear up my confusion?
Sure. And so the FTE that's listed in section 4, the hiring status update, is a combination of experienced positions and trainee positions. So the 13.5 FTE includes both experience and training. So as far as training positions are concerned, they're all filled.
Okay.
So they're really, the vacancies are in the experienced critical care specialty. So those are the ones that are remaining to be filled.
Thank you for filling that gap in my understanding.
Sure.
Thank you, and I want to thank you for the response in terms of looking at the graphs, and they really are much more helpful, and it shows great progress for most of the units, and I think Commissioner Christian has pointed out the critical care one, and it's very easy to see that that is one block that shows a lot more. So thank you for the reorientation for the graphs. Very helpful.
Glad that's helpful.
Okay, should we go on to our next item?
Yes, thank you so much, Emma.
Thank you.
Item 8 is the medical staff report.
Good afternoon, Commissioners. Gabe Ortiz. I'm honored to present our Family and Community Medicine Service Report and Rules and Regulations updates. This was another just kind of wonderful representation of the commitment of our teams. Teresa Villela, the service chief, presented the kind of big footprint that our family and community medicine colleagues hold across our organization. They staff the Family Health Center, which sees over 50,000 patients annually, to kind of some of the overarching values that are embedded within this department. There's a lot of equity and health disparities work that is ongoing in the FHC, including increasing colorectal cancer screenings for all of our patients, especially our Black and African American patients who continue to experience a health disparity. They cover our family medicine inpatient service with over 1,200 admissions per year. Our adult urgent care center, which we've touched on before, incredible partnership with all of the care areas on our campus, especially our emergency department, where the urgent care center has ramped up their capacity by improving their efficiency and their workflows. So they see over 2,800 patients per year, and the lead time for those visits has been shrunken down to kind of less than 90 minutes for the vast majority of those. And they take 18 patients per day for the emergency department in terms of low acuity patients that are better seen in urgent care. We touched on, we'll come back with more information as to why there's been a blip in those 12 patients per day that are going to the emergency room. The leaders of this area have started education across our campus to educate on which patients are appropriate for referring to the urgent care centers. That may be part of the problem in terms of receiving patients that cannot be managed in the urgent care center and need to be sent to the emergency department. But there'll be more root cause analysis there and more understanding that we can share next time we meet in terms of the factors leading to the rise in that. Our family and community medicine colleagues also staff our 4A skilled nursing facility. As Susan mentioned, the capacity of our nursing facility has gone down to 28, potentially down to 26 because of the seismic retrofitting of that area. The team has been very conscientious about the patient experience on that unit. It is very loud, and so working with different factors in terms of mitigating that, and acknowledging how important those beds are in light of the limited skilled nursing facility beds that we have across the city, especially for our patient population. And they staff the prenatal partnership program at the birth center, and they deliver primary care for patients at our mental health rehab center. And so kind of really broad clinical footprint. They serve a big educational role for the med students, for our nurse practitioner students. They have regional projects that kind of serve as great highlights of kind of the education this program does in terms of disseminating knowledge. They have a strong residency program, and many of those graduates often stay within the San Francisco Health Network, and so they create a pipeline. Teresa reflected on the fact that usually they have 14 to 16 graduates that stay and work within the health network. In the last class, it was down to 12, but that's something that she's watching closely. And this group kind of serves a variety of kind of community and leadership roles. And so they have a presence at O'Connell High School. They're driving equity. And if you've had a chance to take a look at the link here, there's just a lot of wonderful equity projects that this group is leading. And they've received great awards in terms of teaching and kind of being part of the Academy of Medical Educators for select faculty. And so they have had several faculty transitions, and so those were acknowledged. Our kind of beloved Hallie Hammer, Jack Chase, Ron Lobugan, who is the medical director for our urgent care center, is also transitioning. And so there are kind of leadership transitions that we're kind of looking to fill. And so they presented quite a wonderful report. I think that the key challenges that Teresa reflected on, kind of their family health center space, the leadership transitions, keeping up with kind of retention in terms of keeping up with salaries to kind of for other opportunities across the local Bay Area, and collaborating on anti-racism at a structural level, which they aspire to do. And then strengths, really a talented team, really committed team, continuous support from their various leadership members, a quite mission-driven group, and patients who are quite engaged in family and community medicine, doing better for our patients. Specifically around some of the questions, I sent Mark some supplemental information with respect to higher resolution org chart, details around our census sharing protocols. I should say the family medicine inpatient service works in close conjunction with our internal medicine group, as well as our cardiology group, to census share. So it kind of teams are level loaded as much as can be possible, and that they back each other up when one service gets overloaded, so that they have protocols for kind of spreading the work in that way. That's been quite critical during the busy winter months. And in terms of the rules and regulations, which I've submitted, the Appendix D, which was included, was just the front index or table of contents for a larger document that exists on a shared site for their faculty. And so that was provided as well via email. The missing pages in the edited or the track changes document has to do with removal of all of the contents of that document that are now found online in that shared space. And specifically around the additional 2 questions that I received in advance, with respect to colorectal cancer screening, the Family Health Center and their primary care sites perform yearly fit testing for patients 45 and older, unless there's a high-risk condition in which they go straight to colonoscopy or sigmoidoscopy, depending on the condition that has led to the high-risk state for the person. And anyone who screens positive via that the FIT testing is then referred for colonoscopy. As shown in some of the slides from the presentation, there remains a disparity rate for Black and African American patients with respect to colorectal cancer screening. I don't have the exact number of how many patients, Black or African American patients, who screen positive for FIT testing versus fail to follow up for the follow-up colonoscopy. So I'm trying to get that from the QI leads within the family and community medicine group. They have done a lot of initiatives like panel managers, health coaching training for the teams in the FHC. Their annual retreat focused on health disparities, how to address microaggressions, how to address power dynamic differences, in attempts to try to address kind of some of the health disparities that they're seeing. And to the credit of the team, they have decreased the disparity from a delta of 19% to 10% over the time that they've been doing some of this work. But the disparity in colorectal cancer screening for Black and African American patients persists, and that's something, a target of ongoing work for this group. And in terms of the staffing challenges and leadership turnover, On the clinic staffing side, Teresa reflected it's been a lot better than in the past, but they still experience challenges with kind of staffing. They're working with HR to ensure prompt reviews of vacancies and then kind of very quickly moving to interview and hire folks as soon as the approved lists are provided. Right now, the family community medicine clinics are short on nurse practitioners, and that's kind of an area of active recruitment. And in terms of the leadership turnovers, I alluded to Ron Labugan, who's been the medical director for our urgent care center. He's been in that position since 2016, and then was prior to that an assistant medical director. And he's leaving ZSFG for a leadership position within UCSF Health, which is a nice opportunity for him. So to the credit of Susan and the rest of the team, kind of growing leaders that are kind of quite desirable for organizations around the Bay Area. And then in terms of the other leadership position that Teresa reflected on, the residency program director, Diana Kaffa, who's directed the residency since 2014, will be stepping down this summer. And so that'll be another kind of leadership vacancy that she has her eyes set in terms of filling. There are no standardized procedures and no changes to standardized procedures or privileges list. And I will stop there for questions on the family and community medicine service report and rules and regs.
Commissioner Christian?
Thank you. Thank you for the presentation. I have a question on the Family and Community Medicine Service Report, Section C, Community and Leadership, under the education section, I guess, beyond the education section. So a newly developing program at the Wellness Center at O'Connell High School. And so does that mean, is that referring to wellness engagement, classes, screenings, all sorts of things? Is there any, can you elaborate a little bit on what kind of engagement that is?
We didn't dive too deeply in our medical exec committee on specifically around some of the details here, but I'm happy to get those from Teresa in terms of what exactly they're doing. I know that some of their providers are very focused on pipelines for kind of into health related fields, but I'd have to kind of ask her specifically around what this particular program is targeting.
That's great. I would love more information, a presentation on the kind of engagement that is being done with the youth in high school pipeline or otherwise, because obviously disparities happen from the beginning, and this is an excellent chance to address all of them, begin to address all of them.
Yeah.
So really interested in knowing what the plans are.
I'm happy to get more information on that.
Thank you.
Commissioner Green, any questions now? Thank you for this wonderful summary and for the additional information that you've provided. It's really quite a department, especially, and geographically within your campus, it looks like they are in almost every building. So very impressive. Okay. Thank you.
Been wonderful partners. Urgent Care Center being one example of kind of stepping up to fill various needs during the pandemic and beyond in terms of standing up vaccine clinics, kind of setting up the streams of patients, low acuity patients from the ED back to urgent care for more appropriate kind of level of care and kind of partnership in that way.
Very good. You want to go on to your action items?
I
think they were your clinical service rules and regulations that you were asking us to approve.
The rules and regs, so I've kind of attached some of the changes here in terms of the questions that were brought up.
Yes.
And the kind of tried to explain why there was a big kind of deletion because that document that had been moved online.
Sure.
I don't have any other kind of highlights, but I'm happy to take questions on kind of the rules and regs.
Okay, any questions on the rules and regs? No. So a motion is in order to, do we accept these or we recommend to the?
Recommend to the full commission.
To the full commission.
It goes on the consent calendar.
I forget what we're doing nowadays.
It's okay.
All right. So We need a motion to recommend these changes to the full commission for acceptance.
So moved.
Second.
All those in favor?
Aye.
All right, thank you. Thank you very much, Dr. Ortiz. Item 9 is other business. Hearing none, seeing no hands. Item 10 is public comment. We have no public comment. There's no public in the room. Item 10 is a consideration for a closed session.
So a motion for a closed session is in order?
So moved.
And a
Second.
second, all those in favor, please say aye.
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 All right, would someone please close the back door and then give me 30 seconds to take us out of open session and wait till I let you know we're there, please. Right, we're back into open session. Commissioners, please consider a motion to disclose or not disclose discussions held in closed session.
I move to not disclose discussions held in the closed session.
Second.
All those in favor?
Aye.
And now a consideration for adjournment.
Move to adjourn. Beat you.
Second.
All those in favor, please say aye.
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 Thank you, and thank everybody for the